ના હવે કરીશ ત્યારે વિડીયોમાં જશે ફાઇલ અત્યાર સુધી video
A very good morning to all the members of the Bombay Orthopedic Society, respected colleagues, friends, students, and all the orthopedic surgeons around the country and around the world who are watching. On behalf of the Bombay Orthopedic Society, we welcome you to the second clinical meeting of this academic year. This meeting is being conducted by the Bombay Orthopedic Society and is being hosted by the Lilavati Hospital. This meeting is being sponsored by the Crossland Division of Sun Pharmaceuticals. Sun Pharmaceuticals Crossland Division is committed to support academic initiatives and scientific knowledge on various sharing forums in orthopedics. I now hand over the proceedings of the meeting to the Honorable President of the Bombay Orthopedic Society, Dr. Sangeet Gawale.
Good morning and greetings to all of you from Bombay Orthopedic Society and the Executive Committee. So this is the second e-clinical meeting of this year, and we have stalwarts from Lilavati who have beautiful cases lined up till 1 o'clock. And similarly, we have faculties, chosen faculties in each specialty who will be giving inputs, and the discussion will be very, very useful to each one of you. So we start with the first case, and I hand over to Dr. Rajesh Mania to begin the proceedings.
Good morning, friends. Thank you very much, Sangeet. At the outset, let me thank Bombay Orthopedic Society for allowing Lilavati to host this. I must also congratulate and thanks Dr. Vishal Kunnani for working towards it and making it happen. We at Lilavati, all the consultants have worked hard to put up cases which will generate a lot of discussion, and that will help us do better job tomorrow and day after. Without further ado, let's get on with the first case of today. Dr. Pranav Agarwal is going to present. It's on the hand surgery, and we are going to have expert panel of Dr. Karkhanis and Dr. Agase to moderate that discussion. Pranav, please go ahead.
Yes, sir, I'll take over.
Go ahead, Pranav.
So good morning all. Welcome to the Bombay Orthopedic Society clinical meeting, which is this time being hosted by our hospital, Lilavati Hospital and Research Center. At the outset, thank you, President Sir. Thank you, Maniyar Sir and Dr. Kunnani for having all of us together on this Sunday morning. Fractures of the small bones of the hands are always a tricky treatment protocol. Although these small bones often behave like long bones, but many a times the treatment protocols are far different from how we treat long bones. In the words of Swanson, fractures of the hand can be complicated by deformity from no treatment, stiffness from over treatment, and both deformity and stiffness from poor treatment. So the primary objectives of phalangeal fractures specifically should be that anatomy should be restored, function should be preserved, there should be minimal soft tissue injury, early mobilization, and early return to activity as we know it. That's our case. This is a 31-year male. This is his right dominant hand. He injured his little finger while playing cricket, and he presented a little late. He was at our clinic on the 12th day when he found that the pain would just not go away. He had no comorbidities. He likes to play for the local cricket association, and this was a closed injury. So looking at the fracture in detail again, let's put it up to the expert panel, Agashe sir, Karkhanis sir, and we have Warrior sir also live with us. I request Dr. Warrior to give his expert opinion and experience on treatment of such fractures, and how can we go ahead in this particular fracture.
Right, this Pranav looks, it's 12 days old. He's a young man, and
an active individual, and this looks
Yes,
like a very difficult fracture, but a very typical cricket injury.
Yes, sir.
And this is like a pilon fracture where you have both the volar and the dorsal lips, so to say, of the middle phalanx fractured and widely separated, and an
Yes.
unstable shaft. So it's a
Yes.
very difficult fracture because you need to control all three of these, reconstruct the articular surface, and mobilize them early.
Early.
So there are very, like you put it up on the side, there are different ways of approaching this.
Yes, sir.
My personal preference would be to do an open reduction and fixation,
Yeah.
or use an external fixation when I find it more that the fragments are much smaller than the implants that I have.
Okay. So obviously, as an orthopedic surgeon, and given the nature of this intra-articular injury, leave it be is definitely out of question. Strapping and mobilizing is also out of question. So coming to the point that you raised, sir, external fixator, would you like it to be a fixed external fixator like a JES fixator, or would you like it to be a dynamic one? The one that we can mobilize the finger soon?
Right. So the ones that I would tend to use in a patient like this would probably be a static fixator.
Okay.
Across, just applying traction, reducing the fragments with manual pressure, and
Okay,
holding the large fragments in. So it would be like a hybrid external fixator.
Okay. And if, sir, could you also shed some light on what difficulties we could face if we were to do an open reduction, perhaps bring an anatomic reduction and then put a fixation and then mobilize the finger?
It's one of the toughest fractures to fix. So the dorsal part, I would pin it down after reducing the middle phalanx. And on the volar side, I would have to put in a plate. These are 1.3 millimeter screws. Very, very difficult. But then you get a fairly good articular surface. May have to put in a little bone graft sometimes.
Okay.
And then mobilize them. So it's a very tough thing. It's taken me many, many years to say this, but I've always been afraid of this fracture and used an external fixator in most instances.
Yeah, so an external fixator will help us decrease the soft tissue injury that we may cause when we go in and try and open reduce and fix it, because it's key that soft tissue be manipulated to the least in these phalangeal fractures because they lead to significant stiffness in the end. Karkhani sir, Agashe sir, would you like to put in some views on how you manage these fractures?
If it is difficult for Sudhir, I will not even enter that room.
Indeed, indeed. Okay.
Yeah, that's right. I think Sudhir has aptly said everything on that. And one has to realize, and I think he has done this presentation several times on intra-articular fractures of the phalanges. An important thing is to align them. This is not a fracture, it's a fracture dislocation. As you said, it's like a pylon, but pylon is way, way ahead of this because pylon is weight bearing. This is little finger, but the principles are the same: anatomical reduction and fixation and mobilization.
Okay.
So, probably it is something like a dorsal Barton, where the proximal phalanx has subluxated along with that fragment post dorsally.
Yeah. So would you prefer to do anything specific in this? Dr. Warrior says he would prefer an open reduction in this case or an external.
Do we normally do CT scans for such intra-articular fractures also? I mean, since you are aiming for anatomical reduction, is it really wise and advised, or no? Enough information is out there.
I would probably do a CT scan to scare the patient and make him willing for the surgery, but otherwise it adds nothing. It adds nothing to my knowledge after looking at the X-ray.
Right.
So there is one modality called percutaneous fixation of K-wires. Do you advocate that in this kind of fractures?
Not really. It's not going to be very useful in this one.
Okay.
But yes, I've used it in the past and I've failed very often.
Okay, so that's a general idea. Most of us are in favor of external fixation or probably an anatomical reduction in internal fixation. Here's what we did. We used something called as a Suzuki frame. A Suzuki frame was described long time ago by a Japanese professor, Suzuki-san, and he described a pin and rubber traction system. I'm going to highlight upon that soon. But see, this is a very simple frame that we've put in. it goes, I'll come to that in the X-ray picture also. It's a simple thing. There are just 2 wires involved, just 1 millimeter AOK wires that we drill in. It does not require some very heavy inventory. Simple C-arm, simple arm board, twisting the wire and fixing it upon itself. What it does is that it gives dynamic traction at the fracture site, which is the proximal interphalangeal joint. It reduces the dislocation. And while we are at it, it can also allow early range of motion of the proximal interphalangeal joint. These are the C-arm views that we have. See that at the fracture site in the proximal interphalangeal joint, we can already see some distraction of the joint. This is an immediate post-op X-ray. We can see that there is distraction. It takes a while for this to act. And what we can do is immediately, as soon as the ring block anesthesia is worn off, we can let the patient put the finger through full range of movement exercises. Initially passive and then active as well. This is an X-ray at 6 weeks. Notice that those fragments of the volar and the posterior side on the dorsal side have almost fused with the shaft. The shaft has literally gone off, and you can see that the articular surface has slowly begun to remodel. It's not very apparent at 6 weeks, but it's slowly going to become more and more apparent. This is the function that we got at 3 months. Look at the little finger. He has about, say, 65, 70 odd degrees of movement of flexion at the proximal interphalangeal joint, another 30 degrees of movement at the distal interphalangeal joint, which also becomes stiff when we try and put other modalities. In this modality, it does not get so stiff. So you can get a good movement and he can get a better grip because of this as well. So the principles that prompted our choice of treatment in this specific fracture was that it was a comminuted fracture of the base of middle phalanx. It was a late presentation, 12 days. So already the fracture site may have started getting gummy. It is a minimally invasive modality. You just put a wire through the axis of rotation of the proximal phalanx and through the neck of the distal phalanx. That's it, percutaneously under C-arm guidance. There is no soft tissue dissection at all. It affords distraction at the fracture site, ligamentotaxis. Therefore, all these fragments will align themselves and you can immediately mobilize. There's no need for fancy instruments or setup, and it is in accordance with all of Swanson's observations. Now, here is the other part. This gentleman, same guy, same hand, a year onwards, same mode of injury while playing cricket, and this is an acute presentation in the middle finger, same middle phalanx base. I'll just give a minute to appreciate the X-ray here. But while we are at it, also look at the lateral view and the little finger proximal interphalangeal joint. See that that articular surface has remodeled. He's getting good movement at that site as well. This was 1 year on. He didn't come to us after 3 months, so we didn't get the X-rays at that time, but this is as recent as February 2021. He also has a mallet finger in the same middle finger. So this is what we did again, this time in an acute setting. We did have to put a external block wiring for the mallet finger, and therefore we had to immobilize this finger for a while. The process remains the same even in an acute fracture. There are 2 pieces to that volar aspect, and I'll put in a series of research later which shows that it is very good to do this dynamic Suzuki frame in this sort of fractures. Look at that. That fracture has already tried and reduced itself. We have put him through early range of motion after we immobilized for the mallet finger, and this is the result at 6 weeks. That part of the that volar part of the proximal phalanx has nearly united, and it will remodel soon because we will put him through early range of motion. So coming to the part of literature, this is the original pin and traction system which Suzuki and his colleagues had developed in 1994. Deshmukh, Sable, and many other researchers put in a lot of papers where they showed the success of this sort of a frame. Richter et al. Put in a long-term follow-up of Suzuki frame. So this is not just good in the immediate post-operative period. They studied 26 patients and they got a good flexion of 85 degrees on an average, and with no extension loss and a good range of movement at the PIP joint. Look what they said in that last point. X-ray showed an initial anatomic reduction with complete joint congruency only in 20% of the cases. But over time, there was extraordinary remodeling of the joint surface in 89% without obvious signs of degeneration of the joint. So there is tremendous remodeling potential in this cartilaginous part, unlike the other long bones that we treat. This
Pranav,
is,
I think you can.
Okay,
yeah.
wrapping up. So this is a recent ongoing study. They will publish in some time. They had a very similar fracture like ours. It is applicable to Rolando fractures and fractures of the base of proximal phalanges as well. So it is a simple, cost-effective method. Complex comminuted intra-articular fractures can be treated. It's dynamic, so early mobilization can be done. There's hardly any soft tissue dissection, good short and long-term results, comparable ROMs and grip strengths as compared to the opposite hand, good remodeling at articular level. It can be used in acute and late settings, and there are very few complications. So these are certain fractures where we can definitely use a simple dynamic Suzuki frame. I'm going to stop here. Thank you very much, everybody.
Thank you, Pranav. That was a very good illustration explaining the technique. We'll proceed to second case by Dr. Warrior, which is going to be presented by Dr. Shetty.
I think Dr. Agashe has a point to make.
Yes, Dr. Agashe.
Just a query.
Yes,
how do you control excessive distraction? Because I've seen two patients where the distraction was excessive.
Sir, in this case, when we have used a modified dynamic Suzuki frame, we use 1 millimeter AO wires, and we turn that distal wire upon itself or the proximal wire upon itself 1 centimeter away from the distal wire. And what we can do is we can change the inclination of that wire. So it should not be just 90 degrees every time. We can change that angle, and because of the initial elasticity of the material of that wire, the distraction is afforded by the elasticity of the wire. So if we just change that angle, then we can decrease or increase the amount of distraction force that we are putting at it. It can be changed, sir. And we can do it on an OPD basis at a later date also. Suppose at the first follow-up a week later, if there's more distraction than we need, we can change that setting.
One question from delegates: can Suzuki frame be applied to distal phalanx also?
Yes, the base of distal phalanx can be treated in this manner. If the base of distal phalanx has a comminuted fracture like we had here, it can be. Mallet fingers and such are not amenable to this Suzuki frame, as per my experience.
Pranav, you have
Yes, sir.
shown two cases.
Yes, sir.
One in which the proximal phalanx was displaced dorsally, and in the other it was displaced volarwards.
Yes, sir.
Right? So is the angle of your distraction, how do you choose the angle of distraction? Because if you just go on distracting, you will never get that reduction. And it is a monoaxial frame.
Yes.
So like suppose if this is the situation, if you go on distracting, the joint reduction will not occur.
So
how do you achieve to displace?
So in the fracture that we showed, sir, which consisted of the base of the middle phalanx, what we do is we put the first wire actually in the center of rotation of the proximal phalanx. So it goes perpendicular to the condylar axis of the proximal phalanx. So that maintains the line of rotation. That is one. And second thing is the other wire which goes through the neck of the middle phalanx, that goes parallel to the first wire. So essentially what will happen is that when you flex the finger, at that time the flexion comes in one plane, that is correct. And we have seen that towards the end, because the little finger is very important for grip, not many rotational deformities are seen at the end of treatment. And
Pranav, my point is,
sorry,
like, how do you correct the translation and reduce the joint? That is my point.
It
occurs
does not
automatically?
Yes, it does.
Okay.
Yes, it does.
Okay, fine.
Yes, it does.
So
Yes,
we move on to next case.
Thank you, sir.
A very good morning, everyone. I'm Dr. Nikita Shetty. So here is a 36-year-old male patient who fell from his two-wheeler and presented to us with this X-ray, which shows an intra-articular multifragmentary distal radius fracture with a volar subluxation of the radiocarpal joint. What we did was fix this fracture with a volar plate, and the plate seemingly looked like it is holding the fragments into alignment, But a few shortcomings of this fixation was that the radial styloid screw was not properly placed. Therefore, the radial styloid was not held properly, and all the screws on the distal row were not filled up. So when this patient presented to us at 5 weeks, it looked like the radial styloid fragment, which was unsupported, had jumped volarly beyond the plate, which due to which the patient had restricted range of motion and a volar sag at the wrist, and his rotations were severely limited. So I would like to ask our expert panel about how do we go about this case next.
What is the new X-ray showing?
Can you put up the X-ray, please?
Yeah, that was at 5
weeks. Here he has used the variable angle plate, but none of the screws have gone into the radial styloid. So that was the problem initially.
Yes, exactly. So we did not hold the radial styloid with the screw that actually should have gone into it. So that caused the styloid to jump over.
If I may just interject, this case was operated elsewhere.
Yeah.
And came to us like this, with the surgeon having marked it with a pen that this is what a initial, if you go to the X-ray before this, so he had marked it to show the patient that I had got it reduced. And then at 5 weeks, when he saw this, he panicked a little bit and he said, he referred him to me. And that's how the patient came to us.
Sudhir, is the preoperative CT available?
No.
And can you go back to the first X-ray, preoperative X-ray? So this is a volar shear fracture.
Yes.
And it involves both the volar lunate and the volar or the styloid process.
Absolutely.
Okay. Now, next slide. So what has been fixed? Is the lunar fragment addressed properly? There's only one screw, and probably that is also not holding it well. So do you think it is only the styloid process which is not fixed and that has resulted? Because the subsequent X-ray.
Next X-ray.
Go the next X-ray. Yeah. So again, the carpus has shifted.
Right.
So only a styloid process will not give rise to that shift unless that lunate fragment is not addressed well.
Right. So that is correct that the most of the international attention is on the volar lunate fragment, and all attempts are made to try and get that into place. Now here it was fortunate, like we used to use in the old days when you have a volar Barton fracture, we used to use the small T-plate without putting any screws in the distal fragment. So this has buttressed the volar ulnar corner, but has failed to address the radial styloid fragment, which was comminuted, as was very evident, and therefore the forces of flexion and extension have taken the carpus along with the styloid and allowed it to move volarly and sag again into the preoperative position.
Or
Sudhir, do you agree with the choice of this plate, or would you go in for a rim plate right in the beginning?
I think the choice, sorry, sir. I think the choice of the plate probably is okay if used properly. There's enough evidence to say that, number one, all holes in the distal row have to be filled.
Or probably the trajectory of the radial screw. This is not the normal trajectory.
Absolutely.
So probably it has not been fixed well with the locking screws which were available. And similarly on the ulnar side, that empty hole is not fixing that lunar fragment adequately.
Correct. So, and the plate is rather proximal. So this plate could have moved a bit distal. So it would have got one edge of the radial styloid fragment. The trajectory of the radial styloid screw should have been correct. Then probably this would have been stable enough to withstand the forces that have displaced it now. So having missed out on 2 points, the problem has occurred.
Also, the volar tilt of the distal fragment was not corrected. I think there was always a volar tilt of the dorsal fragment, if you see in the initial film. So that contributed. Look at this.
I think it could have been slightly more distal to buttress that volar fragment, Sudhir. It's way away from the watershed line.
Yes.
And in addition, they have lost that variable angle thing that has not been used to put one screw in the radial styloid. Plus, I guess you should put one K wire from there, because so much of combination, whether that screw is holding or not, you put additional wire through the radial styloid into the radius.
Yes, it would be an indication for radial styloid stabilization by whatever means, K wire, separate plate, or a screw, depending upon what you like and what is possible.
Do you advocate brachioradialis
release
at this stage? Possible that it was not done?
Yes. You're saying at this stage, meaning at the stage that the patient has come to us?
No. When it was operated for the first time,
primarily,
possibly it was not done, and that also would lead to something like this.
It would put abnormal force if you're going to mobilize him early without stabilizing the styloid. Obviously, you've got a loose fragment and you've got something that's going to move it.
Correct.
So definitely one of the points that would have caused the problem.
What is your experience with a styloid plate, a lateral plate, in addition to the volar plate?
Yeah, exactly. Stabilization of the radial styloid was essential, either through this plate or separately.
Okay.
Separately by wire, screw, or plate.
Okay.
Actually, Sudhir, if you analyze the X-ray, almost 50% of the articular surface has got no purchase.
Correct.
So it's just not like the radial styloid shell or the tip of the styloid. It's actually almost 50% of the articular surface which has not been grabbed at all.
Absolutely. Great pickup that is, because that's exactly where we are headed. I think it's 7 minutes. Nikita, can you go on, please?
Sudhir, Dr. Anil, to say something.
Sorry.
Sudhir, since there is a problem here, if this case was given to you first, what would have been your plan?
I've done numerous such cases, and I've added an extra K wire from the distal from the styloid.
Styloid to radius obliquely or under the articular surface from radius to this, because there's some amount of subsidence here also.
Yes. So once you have a good screw in the styloid, you can have additional wires either, as you mentioned, across the meaning parallel to the articular surface, 2 or 3 millimeters, like a raft wire, or fixing it down to the main fragment, or both. So I've added additional wires, and that's the way to go, because all you're looking for is stabilizing it for a period of 3 to 4 weeks. It's cancellous bone. It'll become strong enough for you to mobilize. Be a little slow on the radio-ulnar deviation of the wrist. Only concentrate on the mid-carpal movements in the first few weeks of physiotherapy. And once this comminuted fragment is fairly stable, or gummy as we call it, then mobilize it better.
In the first phase, you will add 1 plate or 2 plates?
I prefer not to use 2 plates. I've very rarely used 2 plates. Though if you look at literature and you see many presentations, 2 and 3 plates are very common, but I think it's a bit of a difficult job, and it's probably overkill.
And you will always release brachioradialis here?
In this case, primarily, I may not have done it.
Okay.
If I'm stabilizing it, I would.
Sir, can we move to the... Can you move ahead?
So we got a CT scan done which confirmed the volar jumping off of the radial styloid. And intra-articularly, again, the radial styloid was lying volar to the plate. So we went ahead and removed the plate and used a rim plate with 2 screws into the radial styloid, thus stabilizing this unstable fragment. And this is at 1 year, where the fracture went on to heal very well with very good alignment and a good radiocarpal and distal radioulnar joint. And the patient regained good functional range of motion. So Mudgal and Hastings in 1993 studied 11 patients. It was a retrospective study of distal radius fractures with scapholunate disruption, in which they showed that 9 out of 11 patients had a radial styloid fracture associated with scapholunate disruption. So when we went back and looked at the CT scan, it indeed showed Mayfield stage 1 scapholunate disruption where there is diastasis of the scapholunate joint. Johnson in 1980 said that the strongest ligament lie volarly and radially. Therefore, when there is a styloid fragment, when the fracture is at the base of the styloid, it migrates with the carpus because these ligaments are intact. And surgical fixation of this fragment usually stabilizes the carpus to the wrist. So there have been many studies about radial styloid fractures associated with scapholunate disruption. And this is the longest follow-up of such cases where 3 out of 11 patients who had radial styloid fractures, styloid tip fractures, and 1 had a radial styloid fracture. And all these patients were fixed with open reduction, but the patient with the radial styloid fracture did better, again, because all the ligaments are attached to the styloid, therefore stabilizing the wrist. So a few lessons that we learned from this case are all distal row screws should be passed appropriately to hold all the fragments in such cases where the fracture is unstable. The radial styloid stabilization is as important as the ulnar corner because we very often concentrate on the ulnar column and forget about the radial styloid. And one should not hesitate from using an additional radial styloid plate if it is needed. Thank you.
So the role of X-Fix.
X-Fix, I have used X-Fix in the past and quite successfully. The only caveat to that is that you must have accurate reduction. If you get accurate reduction and you stabilize it with a hybrid fixator, which means you have wires fixing those fragments to each other, then an X-Fix will definitely succeed. No question.
Sudhir.
Yes, sir.
Yeah, I give a lot of importance in the distal radius intra-articular fractures to the gilula lines. The gilula lines are so accurate in predicting whether the carpus is going to collapse. That is the lunar part and the scaphoid part of the distal radius. So if you draw these lines from the proximal radius to the proximal carpus, then proximal row, and between the capitate and the hamate, you know what is going to happen. So that is what I would do that first. The gilula lines are very important, and that is often missed for those patients who come with intra-articular fractures which are not managed in that manner.
Absolutely, sir. Very important point to look at the scapholunate joint in all intra-articular fractures of distal radius. And once you've done the reduction, as Nikita pointed out, if the scapholunate joint is looking good, you need not put wires, you need not repair it. That is why we get good results in many of them. And in this case, it highlights exactly that. When you see the preoperative X-ray, the gilula lines are absolutely maintained. And that is why she only went back to the CT scan where when we look back later, we realized that there was, but in the post-op X-ray, second time surgery, it was reduced. So your point is well taken, but the point that she made covers up the fact that if it's a tip of the styloid with scapholunate or a perilunate kind of injury, those do bad. And the ones that have a large ligamentous support with the big fragments, they do well once you replace them correctly.
In addition to what Nikita has concluded, anything else you want to conclude from this beautiful case?
It's a common fracture, and quite often we don't understand why this is happening. So the thing is, when you use implants, use them to their best advantage. They've been designed perfectly to use well.
So he had achieved the anatomical reduction, but missed that large styloid fragment.
Yes.
And it was a brachioradialis pulling force which distracted and displaced it.
Yes.
So the trajectory should have been properly, as you said, or an additional plate, as Nikita has said, or a wire could have been added. So we conclude this case and now move on.
Thank you.
Rajesh?
I think, I said the plate little more distal would have served the purpose, one or the other thing. Now let us move on to the next session, which is trauma and arthroplasty. And I invite expert panel of Dr. Harish Bhende, Dr. Nilen Shah, and Dr. Mohan Desai to question the speaker. The first presenter is Dr. Jawahar Panjwani. Go ahead, Jawahar, with your case.
We also have a trauma panel with us, sir. Dr. Agashe, Dr. Karkhanis is there.
Yes, so that stays on. These are the additional. Are we ready with Jawahar's? Can you share the screen, Jawahar?
You are muted. Jawahar, you are muted.
Jawahar, unmute yourself. Can you share your screen?
Yeah. Am I visible now?
Yes.
Okay.
Go ahead.
So this is the case that I'm presenting today. Basically, this patient is a 35-year-old male driver by profession who sustained a closed femoral shaft fracture on the right side in December 2012. And the index surgery of 95-degree DCS was implanted. This patient was operated elsewhere. I kind of inherited this patient later. So whatever sketchy details I got from the history, unfortunately, he did not have any discharge summaries and all that. But whatever sketchy details I could get from him, I've tried to sort of compile. He started draining from February 2013, approximately 2 months after the index surgery, which was managed with dressings. No active treatment was done. He had a fall in the middle of February in 2013, where the implant broke. A revision DCS was done in February 2013, but the drainage did not stop. It kept draining all through 2013 and 14. In 2014, a uniplanar external fixator was applied, which was kept for 7 months and then removed. After which, a polypropylene thigh brace was advised to the patient. When the patient presented to me, there were no sinuses, but there was frank mobility at the fracture site. There was a shortening of approximately 3 inches, and the knee range was 0 to 100 degrees flexion. This is some of the X-rays which I could trace from the past history. This is the X-ray showing the external fixator in place, where the previous surgeon had tried to stabilize and get a kind of alignment. And I think some kind of local drug eluting or cement eluting was used, local antibiotic was used. But unfortunately, even the fixator did not work. And ultimately, he came with this X-ray where he was given a brace and he was moving around on a walker. And obviously, he had given up his profession, driving, etc. So this is what was the X-ray situation when he presented to me. So now I would like the expert panel as to what would be their plan of action in this case. What would they advise the patient? How would they proceed with this case?
There is no infection at this stage.
At least, yeah, the blood markers were fine. There was, except for the old scars, there were no discharging sinuses. But there was an MRI scan. Now, unfortunately, what happened was, by the time I could collect all the data, some of his papers had already gone for the typical insurance, the claim and all that. So he had submitted his MRI reports as well as MRI scans. But yes, the MRI did show sequestrum and granulation tissue at the fracture site. But this is after he was investigated by me. He did not present with any fresh MRIs. We got the MRI done.
Vinod, your opinion? Unmute yourself. Vinod? Vinod Agrawal.
Yeah.
Yeah, unmute yourself. Yeah. Your opinion, please.
In this case, I think the fracture fragment, they need to be fixed and maybe an external fixator with the Elizara with the bone transport will be better because the middle fragment is gone. I don't think it has got any vascularity now at 7 years. Maybe excision of the avascular piece with the Elizara and transport, bone transport can be a better answer because you can achieve the lengthening also, which is shortened by 3 inches.
Harshad?
Yeah, first
first we have to rule out whether there is any infection actively or no. That is the first step here. And only then can we decide on proceeding further. I would rather not use an Elizarov so proximally, because it's very difficult to apply and difficult to manage. If I have a large gap and there is no infection, I would rather having more in favor of putting a fibula or some kind of internal fixation, provided there is no infection. I would err in favor of that.
Vijay, any different opinion? Don't repeat the same things what have already been discussed.
Yes, sir. I would take it as a case of infected non-union of the middle third shaft femur. I would plan to manage this in 2 stages. In the first stage, I would debride this, remove the sequestrum, ream the canal, and try to put an antibiotic impregnated nail, intramedullary nail. Instead of using a cement, I would coat it with a stimulant. That's a biodegradable calcium phosphate with an antibiotic delivery system in first stage. And if it goes to unite on that, I would keep it for a longer time. Then in the stage 2, the problem of shortening can be managed in stage 2 by lengthening either over a ring external fixator or a rail external fixator. As I said in stage 1, putting a nail, if there are difficulty only in achieving the union with the nail, I will wait and watch and may supplement it with another plate in stage 1B. Usually if the medial cortex is in continuity, I don't expect any problems.
Mohan, Dr. Mohan.
Yeah, I think the same thing as Dr. Vinod Agarwal said. The central piece appears to be sequestrated, and there is going to be a big gap there. You can put in a sort of a Masquelet sort of a technique. We are not sure of the infection, and combine that with the nail there. That is the first stage, and later on again the internal fixation and in the form of a span plating or bridge plating, and copious graft along with the auto and along with the bone graft substitute there.
So Jawahar, all of us.
Can I make a point here? I had a detailed counseling session with this patient, and he said, "Sir, please don't tell me anything about external fixation. I'm tired of external fixation. I am not going to have an external fixation. I will live with this, but I will not have an external fixation." So I mean, my hands are, I know it's a little unscientific, but my hands were kind of tied. I could not offer him an Elizarov. He said, "I'm not going to do an Elizarov. I'm not going to get it done."
Jawahar, wait a minute.
Yeah.
So at this stage, all the faculties are concluding the same. The segment or the non-union and the ends are avascular. So first thing is we have to clean that out and remove as much avascular bone as possible. So final comments from Dr. Agashe and Dr. Mukhi before he moves on to the further treatment.
I agree with the panel. Just one observation that I would like to share. This also appears to be an absorbable antibiotic cement that has been put. My observation is whenever you see that beyond 6 weeks or 8 weeks, then it is generally infected. If it is a clean-cut wound, then it gets absorbed. It disappears. If it has not disappeared at 3, 4, 5 months, that means it is infected. I don't know whether others have similar experience.
Final comment from Dr. Mukhi, and then we move ahead with the treatment.
You must know the bug. One thing that is very important. Second thing is you debride it, use a Masquelet technique, put in an antibiotic rod and a cement spacer over there. That is the first stage. Second stage, once the membrane has been formed and the infection is brought under control, you use a nail pale technique with cancellous bone graft.
Jawahar, can you show us what you have done?
So that is exactly, this is what the options. As I said, the patient was not keen on the Elizarov frame with transport. So that's what we thought of using the Masquelet technique, as Dr. Mukhi and Dr. Agashe, both of them rightly said. The concept of induced membrane for reconstruction of long bone defects. I'll not go into the details because I'm sure everybody knows about this. So in the first stage, we did a debridement. We got samples from microbiology, samples for histopathology. And luckily, we could grow the bug. We grew Staph aureus, which was sensitive to cephalosporin. So in consultation with the microbiology team, we started the patient on appropriate antibiotics with a PICC line.
Can I interrupt you, Jawahar? What
Yes.
do you mean by debridement? What you did exactly?
So whatever granulation tissue was visible on table, whatever loose bone fragments, we removed everything. You can see a fragment here, which seems to be like a sequestrum, but this was firmly united to the proximal fragment.
Okay, and we still see the
yes. So whatever material was visible. See,
Jawahar, let me complete.
Yeah.
So in this X-ray post debridement, we still see that stimulant or that artificial graft material what has been used, and we still see the ends of the bone sclerosed. So that is why I ask what exactly you did in the debridement. Go ahead.
Yeah. So in the debridement, we did not really open the canal at that time, because I was very sure that we will have to go ahead second stage and stabilize this. So basically, we got the biopsy, we got the sample for microbiology, and whatever debridement was gross debridement we could do, we have done that.
So we still see the foreign body there in that.
Yeah. So that drill bit we could not remove. Whatever stimulant you're seeing is probably a part of the thing adherent to the soft tissues. We removed as much as possible,
so
whatever was visible.
So you cleared the ends of the bone till they were vascular.
Yes.
And the granulation tissue and the fibrous tissue, everything was excised.
Yes, exactly.
Go ahead.
Yeah. And once the wound healed, after in the second stage, we went ahead with again a repeat debridement, stabilization with a corrected length. We could bring him up to length almost about 3/4 of an inch short as compared to the other side. And we put in a PMMS spacer, a cement spacer with vancomycin. And this is the X-ray after the debridement and the first stage of stabilization using the principles of Masquelet. Any comments on this?
I think what you've done is very good, that you put that cement Masquelet technique and you have fixed it also, because the cement in the Masquelet technique has to be stabilized. It cannot keep on wobbling. So what you've done is actually very good, I think. And probably you must have removed it at second stage and bone grafted it.
Yeah, so I'll come to that. So if you're okay with this, then I'll proceed.
Yeah, I'm okay with that.
Okay. So this is the second stage now, stage 3 rather, where we removed the spacer. We harvested a fibular segment, a segment from the fibula, and that was wedged in the gap along with iliac crest and mossealized bone graft. And we took samples again during the third stage and sent everything for frozen section as well as for histopathology as well as for the regular culture, the standard culture.
So what was the culture second time?
No, there was no growth. And this is the X-ray.
This time, Jawahar, or the plate was the same?
No, I did not. No, this is the time when we did not change the plate. No. So this is the proximal.
One can see most of the stimulant beads disappear between the first debridement and second and third debridement. So maybe you could have done that at the first debridement. I mean, I understand it's pretty difficult on day one, but I think that and removal of the drill bit, I would be more comfortable removing all the foreign bodies.
Sir, I feel that the stimulant that we are seeing on the X-ray, a lot of it was already extraosseous to begin with, and it was encompassed in fibrous tissue and scar tissue. So to chase everything, at least in my hands, I think I could not remove everything. So, but at least externally, the infection seemed to be under control. And he was not draining after that. He was not having any discharging sinuses. The wound healed nicely. And we kept him on antibiotics through the PICC line for 3 more weeks. And with strict instructions not to bear weight at least for 3 months till we see sufficient consolidation, because this was like an intercalary graft. So I was sure that, non-union at any of the graft sites would be like kind of a hurdle in the future.
One more suggestion I would make, that
yes, sir.
The medial, there should be one medial strut. That means when you're putting fibula, there should be one strut on the medial cortex from cortex to cortex support. So that would definitely prevent the bending movement.
Yes. So that is exactly what you will see in the subsequent slides.
Jawahar,
Yeah.
Jawahar, I want to ask Agash sir, in the debridement, what you do for such cases or such non-union, is it always necessary to open the medullary canal and remit?
Yes, I would do that. I would do that.
So that is a message. You must, your debridement is not complete without opening the medullary canal, because usually following repeated surgery, that canal is blocked by that fibrous tissue. It is may contain some colonies which has to be cleaned out. So that is a message. Go ahead.
Yeah.
Agash, sir, you mentioned about removing all the stimulant which is being seen. So, like if it is entangled into the fibrous tissue, do you remove all the fibrous tissue around?
Generally, during debridement, as you enter, that fibrous stroke infective granulation tissue is covering the fracture site. And as you remove, most of the times the stimulant comes out.
Okay.
So this is the patient's knee range at 6 months. We kept him non-weight bearing for a long time. And after 6 months only, after seeing the subsequent x-rays, we allowed him partial weight bearing. At the end of 10 months, he was doing well. You can see a consolidation happening at the distal end of the graft, but the proximal end is still not very, very strong. And in fact, I told him to go slow on his activities, to keep coming back for a follow-up x-ray at least once in 6 weeks. But by then he had become completely pain-free. He had no discharging sinuses. His wound had healed nicely. He was not in pain. So I think he became a little overconfident. And he started going back to work. He started driving. And in fact, he sent me a video saying that, I'll just show you very quickly without taking much time. He could literally sit cross-legged, squat, and he was driving all across Maharashtra. He's a professional contract driver. So he was doing all these movements and he appeared to be very happy. Till then, I was also kind of patting myself on the back that maybe he's out of trouble. But I was still keeping all my fingers and literally my toes crossed. So soon after this, the pandemic kind of worsened and he was kind of lost to follow-up. But just 2 weeks back, he presented to me with this X-ray picture. Now the problem is far from over. He's got pain on weight bearing. As you can see, the graft here has consolidated, but obviously there is a gap here. There is no gross evidence of infection, but now I have to investigate him further because it became a little difficult for him to get his investigations done. He's going to get his blood reports, etc. But externally, grossly, there doesn't seem to be any infection. So this is where we are today. I'd like to take an opinion from the house as to what should be offered next.
Dr. Mukhi, please.
No, I think this is the day one compromise or failure, as I put it. You are running a race between union and implant failure. I would have used dual implant, intramedullary plus extramedullary, plus enhancing it, medially grafting. It is not the error of the patient. It is a misunderstood concept that these tension blades succeed. This plate has got a high failure rate. Alone, it will fail.
Dr. Anta?
Was there any role of Lars fixator here and trying to distract and bring down the gap and fix it up? This is one. And second part is when we send the material for histopathology and smear culture, have we supposed to send from the medullary cavity?
Yeah.
Remarks.
Yes.
6 samples.
So the issue here is, Jawahar.
Yeah.
The subtrochanteric area is relatively avascular, unlike the metaphysis where you see a lot of new bone in expected time. In between 9 to 1 months, usually well-fixed subtroch fracture, they give way. Second reason is you never corrected the deformity of the proximal fragment. It continues to be in external rotation. You see that from day one, the lesser trochanter is visible very well, suggesting that the proximal fragment has remained in external rotation, one. Second, there are only few screws which are having a bicortical purchase. If you go back, you will see
Okay.
that.
I'll go back. I'll go back to the slides, the immediate post-op
So
slides.
that is the reason why Dr. Mukhi has said, like here, the screw purchase in the proximal fragment, none of them probably have, or one of them may have a bicortical purchase, suggesting, as Dr. Mukhi has said, additional second plate would have taken care of this little instability what we have. And lastly, the diamond principle from that author, Giannidis. You do everything whenever you have such non-unions. Improve the stability, add as much cortical as well as cancellous graft, stability by single or a double implant or 2 plates. So in this area, this is what usually happens, a non-union in the subtrochanteric area. So what do you plan to do now?
So actually, obviously this implant is failing. So I think we will probably have to go ahead and think about a dual implant, as Dr. Mukhi said, use an intramedullary device as well as a plate, or and of course, lots of, if there is no infection, then lots of bone graft, repeat the bone graft.
So the problem here is you cannot use an intramedullary implant because there is a fibula which has incorporated. Unless you remove it,
Yes.
you'll not be able to negotiate the canal.
Yeah. We'll have to probably try to open up the medullary canal somehow.
So can you sum up? Can you sum up the conclusion? This ends here. The case ends here.
Sangeet, can I just make a comment?
Yes, sir.
So often we have seen that more complicated fractures, more complicated surgery, chances of failure are higher, which is a naturally known phenomena. But I have often got a feeling, both in periphery when I was working at Science and in spine now, that we are too much in hurry to load those areas even before a slightest amount of non-mechanical biological support is raised. I think by all means the part has to be rehabilitated, but it could be done non-loaded, and loaded mobilization of an extremity too soon in a complicated case will always have more difficulty, because biomechanics does not pardon you for that. So in spite of your all struggle, all most intelligent, thoughtful, literature-based care, still things go out of time, because I think somewhere the gravity just doesn't help us.
So can I sum up, Jawahar, on your behalf?
Yes.
Adequate debridement, dual implants, and adequate graft probably would have taken care of such non-union, which you tried to do as best as possible. We move to the next case. Rajesh?
Maniyar sir, you are muted.
Yeah, the next case is ipsilateral fracture neck of femur post-revision TKA. 54-year-old lady had ozone therapy and arthroscopy, post which she developed infection. This was treated with aspiration IV antibiotics in just 2 or 3 months after the procedure. 2 months later than that, total knee replacement was done. I think this is the first point I wanted to make. One needs to be very careful doing a total knee in a post-infection situation. There are guidelines that we should wait longer. And post-total knee, in just 5 or 6 days, she developed acute infection, purulent collection. So naturally, the diet procedure was done by the surgeon who had done a total knee. I think the liner also must have been exchanged because it looked thicker. However, there was no growth on culture. So that's the second point I need to make, that the persistent discharge, one needs to keep the culture for longer time and look for other bugs. In about 6 or 8 weeks, it actually grew non-tubercular, rapidly growing Mycobacterium abscessus. So full first stage revision was done by the surgeon, but I'm not sure what antibiotics were given at that stage. Probably AKT, which is not the right thing for rapidly growing mycobacteria. And the discharge continued. Now the second surgeon did the repeat first stage revision because there was a continuous discharge in the October month. And 2 or 3 days after that, the patient came to me after the second stage revision, first stage revision was done. So we, based on the original antibiotic sensitivity, we gave a 3 month of complete antibiotic that was required, amikacin, clarithromycin, moxifloxacillin. And at the end of 3 months, there was no discharge now. We gave further 6 weeks of antibiotic holiday, following which aspiration was done. And again, put for all the cultures, including mycobacteria. There was no growth after 6 weeks, which is when I decided to go ahead and do the second stage. Because the lateral column was already destroyed and the medial column showed fracture at that stage, I kept ready and did the distal femur replacement. Now, following this, she recovered very well, very quickly, started walking as well, and she was from out of India, but stayed here for 6 weeks and was being mobilized. That's when this problem occurred. While doing the physiotherapy, because she had been immobilized for a long time, she was having this physiotherapy being done for the hip, and suddenly heard a click in the right hip with severe pain. She waited for 24 to 48 hours before reporting to me. She just thought it is one of those things. But when I saw she was unable to do active SLR and knee examination was okay. It was already 48, 72 hours. And this is what the X-ray fracture here. There is a stem from the revised distal femur. And this is where I want to pose the question, what to do? We have she is 54, 3 days after the injury. And the issue is, should we fix or replace?
Can I ask one question to Rajesh?
Yes, please.
Rajesh, looking at the edges of the fracture here.
Yes, sir.
Do you think it looks like a fresh fracture, or it's something which was brewing in and got completed?
Sir, I think it was a fresh fracture because I also thought that this looks like a pathological one to me, but she was mobile very well.
Can you close the pelvis with both hips X-ray?
Yes.
Because that will decide whether we want to do osteosynthesis or whether that fragment is dead, head fragment.
Yes, sir. I think the vascularity of the head fragment looks good, but the edges definitely were worrisome.
On plain X-ray with this kind of appearance, you can say it's good?
I'm basing this thing on the fact that she was really completely pain-free, walking very well. Delighted after almost a year that she was in bed, that after that distal femur replacement, it was only 6 weeks. In a few days, she started mobilizing very well. And I think that although it is possible, and at that time, I was also worried. On the table, we would say we will look at the quality of the bone in the head fragment. But yes, I agree with you that there was a doubt in the mind.
Rajesh, can I ask a question?
In the spine, I can see the metal over here.
Rajesh, can I ask a question?
Yes.
If you disregard that there is a revision TKR below,
yes,
what would you have done? Just disregard that there is no TKR, everything is normal. This patient comes to you after, say, 6-8 months of bedridden position because of some other reason. And because of the bedridden, she may have some amount of osteoporosis.
I think
she falls down.
I agree with your point is whether I would fix this.
Yes. So in this case, because you have adequate proximal femur, you can even put a stem and replace it, or you can do a fixation. Now, disregarding that distal femoral treatment and revision, etc. If you personally feel that this fracture is what you would fix, I think it should be fixed. There is nothing wrong in it.
No, hurry. But only because of these two issues. One is whether that fracture is, what it is, just a traumatic fracture, the way it has happened. And the second, that if I replace it, the stems are going to be almost near each other, and that's going to be a stress riser there. So that is the dilemma going on. Ideally, it needs to be fixed, but you're not sure about the quality of the bone and the cause of the fracture.
There are two things in this X-ray.
Yeah, Sangeet.
It is a subcapital fracture, and the fracture line is vertical.
Correct.
So now on this basis, you decide whether, and we have a doubt whether it is a fresh or an old fracture. So on these two findings, you decide whether you require a fixation or a replacement. Dr. Mukhi.
I would do a primary abduction osteotomy and fixation of this case, seeing that the plate crosses the stem of the knee joint. And it passes, the screws are bypassing the stem, and do an abduction osteotomy with fixation.
Sangeet, coming back to your point, how does one ascertain that, both the points that you raised? Tell me, how do I clinically, is there a gut feeling or is there a way I can ascertain those things?
Regarding which point?
Whether the fracture is acute, vascular head, and on which you said you will decide what you're going to do.
So regarding the vascularity of the head, we can do a MRI, but that doesn't mean that 100% it is going to become avascular. Like it has to be done after 48 hours. But that doesn't mean every head becomes avascular. But after anatomical reduction, with the surviving blood supply, they revascularize.
Right. So, I get your point.
Yeah.
Dr.
Yes, Nilen, what would you?
Rajesh, I would...
Nilen, hold on. Dr. Antav has raised his hand before you. Okay. Let him answer and we come back to you.
Rajesh, there is some sclerosis in the distal fragment.
Yes.
And there is some amount of lysis under the sclerosis.
Yes.
Does it mean we have to see from the pathological point of view? Second part, this patient, if she was limping a bit because of some amount of shortening, was you think there was some stress coming up and one day she suddenly gave way?
So it could be, and I thought that for more than a year she was not weight bearing on that leg, and maybe this is osteoporosis that you're seeing, because if you see otherwise the cortex of the lower part of the inferior part in that distal fragment, neck area, calcar area is very strong bone, but it's just that some of the bone has resorbed. Yes, you're right. So this was a concern.
Nilen.
Yeah, thank you. I think that I would definitely not try to fix this fracture. This lady has suffered enough. By doing an abduction osteotomy and trying to unite this, I don't know whether we would succeed or not. I would try to replace this, look at the short stems also, template this properly. She has a door A type of canal. So fixing the proximal fragment, getting a good fit is not going to be difficult. If it appears that the proximal metaphyseal filling stems are not going to be adequate, I will use a normal stem, and then I would use an additional plate on the lateral side so that there is no stress riser remaining between the previous implant and this implant.
I think this.
Yeah. I would do.
Sir, pardon me 1 second. Dr. Agashe has raised.
Oh, sorry.
And before that, Sangeet, I would want Dr. Vinod Agrawal also to comment, because he was with me. We were deciding this. So Dr. Agashe first, please.
I think Dr. Antav has made that point, and I feel that MRI should be our first step.
Dr. Ingalalika, sir?
Yeah. I would do CT scan here to see the inner raw surface of the broken head. The head fragment inner surface. If it is scalloped and sort of worn out, I know that this is not something very fresh. Because I have seen patients walking pretty comfortably with impacted fractures and with scallops developing inside. So that can tell me if the inner surface is worn out and is too polished or too clean. Perhaps this is not as fresh as we all believe it to be.
Dr. Vinod Agrawal, anything to add?
No, I think this looks like a chronic fracture, and a CT scan will certainly help. Maybe early diagnosis can be achieved for AVN with a bone scan, if it is practical. But I would not certainly try to fix this, because this looks old.
Vinod, we did this together.
Yeah.
And it was definitely a recent fracture, 2 days. 48 hours.
That's what I'm saying. If it is not chronic, then I would certainly fix this. Yeah.
Dr. Mukhi, quick comment. Dr. Mukhi, quick comment.
Yeah, I would fix this fracture and do an abduction osteotomy. And see that the plate...
Sir, you have already told, you have already given the same opinion. Mohan Desai?
Yeah, if you see the other side, I think there is a severe osteoporosis. Primary tensile trabecular disappeared. Primary compressive trabecular severely attenuated. Secondary trabecular not there. There's a very short segment for the fixation in the head. I would go for the total hip replacement in this particular case. A short stem, cemented one. Short stem and a cemented one would be my choice.
And add a plate.
The dual mobility. Yeah.
Add a plate.
Okay. So I think with this, I'll show you what we did. I thought that she is 54 and my first this thing was to fix it. Me and Vinod decided on table we'll judge the quality of the bone in the head fragment. And if that is not really good, we will go ahead and do a hip replacement. But this is what we did. We fixed it. All this we've discussed with DHS and one more proximal screw. This is the on the table intra-op fluoroscopy view. It was a short segment plate. We said we want to be far away from the tip where the stem was. This is at 1 year. Patient was pain-free, good range of knee movement as well. And this is at 2 years where the fracture is united. Luckily, no AVN. Clinically, she is absolutely delighted that walking about both with her knee and the hip. And at this 2-year period, no AVN there. And of course, the X-rays are looking good.
Only thing is you may get a fracture between the two implants.
Correct. And that is why I agree with you. And that is why we've kept the DHS only 2 hole, a shorter one. And it's a chance we've taken. I've discussed that with the patient because the other option is replacement. That is always going to be feasible. I don't know whether you're suggesting to put that DHS plate longer than the stem.
Longer to engage the stem.
Yeah, but I think overall we have a pretty good segment in that area between the two, which is isthmus, a strong bone. So I'm hoping that won't happen, the fracture, because it doesn't always happen. We've had a number of patients where the 2 stems are nearby. It makes it prone to go have a fracture, but doesn't always have. I've tried to look up the literature also to see is there any guideline as to what, and there's none. As to how much and what percentage of patients with that sort of stems pointing to each other are going to develop fracture.
Rajesh, at the 2 years X-ray,
yes,
on the lateral side, there are osteophytes seen which were not there earlier. Even though there is no sclerosis in the superolateral part. So does that point to something?
The joint space looks pretty good, but I take your point. And even if it is developing that way, it's going to be a few years, I would think. And I think for a 54-year-old who had gone through a lot, I'm quite happy to go ahead. But yeah, I think I take your point. It can happen in a few years.
Sangeet, one question.
Yes, sir.
To Dr. Manyar, you pass the CC screw first or the DHS screw first?
No, the DHS first.
So it tends to rotate the head. You have to pass the CC screw first.
So maybe, Vinod, what did we do?
We put in a guide wire always a derotation guide wire is put above.
Yes, so there was a guide wire up. We held that and put the DHS screw
first. Yes.
Last question before we conclude. Now, see, at that time, before you took her for surgery, you were in dilemma whether to fix it or replace it.
Yes.
And you had said you will assess the quality of the head before you fix it. Now, both the approaches are different. The positions are different. How do you decide before?
No, so we have to completely change the position, but it is just the purchase. If you get because of that cavity appearance, it's the purchase that we were going to go by. And we thought there was an excellent purchase when we were, when we were doing the surgery.
Okay. And what standby implants for the hip replacement you had kept on the
So I'd kept both. I'd kept the standard implant and the Proxima because if I have to put a smaller one, we also were thinking of putting a lateral plate if we needed to safeguard that junction. All right. So I think
was reduction difficult? Any special maneuver for reduction, or you could get a reduction?
I think it could come very easily, and we just had to hold it with that proximal guide wire while we were fixing the. Yeah, I don't think it was too difficult to get the reduction.
Manyar sir, please don't send the patient to the same physiotherapist now.
Yeah, I think so. These are the point I wanted to make. That first, of course, the post-infection one should not really be quick in doing an arthroplasty. That was the first where the problem for the patient started. Post ozone injection and arthroscopy, there was an infection. Second, be aware that there can be different infection, rapidly growing mycobacteria or a fungal infection if you don't get initial culture. The stem length, of course, we discussed. Aggressive physiotherapy is not a good idea. And of course, I think in a difficult but young patient, worth trying the fixation, even if it is past initial 24-hour period or there are some other concerns.
Till
Mania, sir,
you share
post
for the next
injection
case,
into the joint,
Jamar has a comment.
Post arthroscopy, how much do you recommend waiting till we can do a proper TKR?
Sorry, can you say question?
Pranav, hold on. Pranav, hold on. Jawahar
Okay,
has
okay.
raised his hand before. Rajesh, Dr. Rajesh, can you ask someone, next person to share the screen? Jawahar, your question.
No, it's an excellent result, no doubt. But I only had one doubt in my mind. If you see the X-rays, both the cancellous screw as well as in the DHS, the screw threads are lying right at the fracture site. So I know it's technically sometimes you get a very short segment in the proximal fragment, and even the shortest length, even the cancellous screw 16 mm also, sometimes you have threads going into the fracture site. So I was just worried about that. Although of course you've got a good union. So just any
So I
comment?
think that is the shortest thread you can have on the distal part of the screw, 16 millimeter, and you are quite right. But I think on the table, we were happy that we are achieving compression. And I think the final union really probably says that that is what happened.
Yeah, of course. You cannot
the good part.
success.
So what?
Okay.
So the good part, what we learned is the anatomical reduction has reduced the complication. Whether you have used a screw which is crossing the threaded part, crossing the femoral head, or if it doesn't cross, it does not make any difference. We don't, and you have seen the fracture has not collapsed. That means the screws have not backed out at the end. So it is the anatomical reduction and a good fixation probably has helped her. Next case.
I think the next is probably we've taken a different case. It is Dr. Priyank Patel presenting on
spine tumor, sir.
Okay, go ahead, Priyank.
Thank you, sir. Good morning, everyone. So this was a 43-year-old lady with presenting with neck pain and stiffness in the neck and right upper limb paresthesia. Her neck range of motion was restricted. There was no deficit, no breast reflexes on examination. So presentation was just neck pain and right arm paresthesias. She had a history of thyroid cancer, which had metastatized to the spine and the sacrum in 2014. At that time, a thyroidectomy was done with a posterior cervical debulking on the right side, along with a adjuvant radioiodine therapy. One important part of history was that during the primary surgery, the right side vertebral artery was injured as the tumor was completely engulfing the vertebral artery. So these are the images when she presented to us, and the MRI showing that there is cervical kyphosis with C5 and C7D1 mets in the neck. If you look at the scans, the central cord per se was not very badly compressed. She had a syrinx which was pre-existent, has been there for a long time, and the CT showed significant destruction in the spine. However, the X-ray, the dynamic X-ray hardly showed any instability, and even clinically, the patient did not present with any kind of instability. So this is the patient, and I would like to open the discussion at this stage.
I think, Priyank,
yes, sir.
We've not actually started the spine session. I don't know how this happened that your case came up.
Oh, sir, because I thought that I was told to share the screen and keep. That's why. You want to? I'm so sorry.
We don't have the spine panel on yet.
So do you want me to stop screen?
Yeah. Priyank, we can come up later. Priyank, we can.
Yes, sir. I'll do that then.
Panjwani sir, please.
Panjwani has a case, trauma, and there is one more after that, and then we'll get the spine panel on.
Oh, I'm so sorry. My bad, sir.
I think all the speakers now, we need to rush a little bit because we want to try and finish as many cases as. So go ahead, Jawahar.
Yeah, I'll just give me a second. I'll just open my second slide.
In that second, can I ask that PTH would have served any purpose for that transcervical fracture?
What would have?
Add on PTH hormone.
Yeah, I think we did give her. We did give her that.
Yeah. Thank you.
Rajesh.
Yes.
That implant that you pass is very constrained, is it not? Because the replacement of the distal femur.
Yeah, it is it's a hinge.
Yeah, so he's going to have stress on the femur all the time. That patient has to be warned on that.
No, it's a rotating hinge, and so that minimizes the forces that are transmitted to the shaft in a rotational torque.
Okay.
Jawahar, can you share your screen?
Yeah, just 1 second. There is some technical glitch. I'm not able to.
All right, then I think we can go ahead with the next case.
Yeah, I can present later. Yeah.
Yeah,
We
Adit,
start
can
with the
you go
next
on?
case. Yeah.
Adit, can you go on with your next case? Yes. We can see your slides, but we can't hear you.
Sorry. Good morning. Thank you, BOS, and it's a great honor to present the case today. I would also like to thank Dr. Vinod Agrawal and Dr. Rajesh Manyar for giving me the opportunity to present this case. My case is a supracondylar fracture above TKR in an elderly. So this is an 82-year-old female who came with a significant fall and pain around the right knee. She has tunnel vision. Her primary TKR was done by my father 10 years back. A PS knee was used, and she was mobile and independent before the fall. And she now comes with a supracondylar fracture, Lewis and Rorabeck type 2. Just to summarize the classification, a type 1 is an undisplaced fracture with a stable prosthesis. Type 2 is displaced fracture with a stable prosthesis. And type 3 is a unstable prosthesis with a displaced or undisplaced fracture. These are our current x-rays. You can see a periprosthetic type 2 fracture. What would your plan be? Think the first two options that you would go with, whether to fix or to replace. And may I have the expert panel's comments on this?
Adit, can you go back to the last slide?
We
can have a discussion. The X-ray. Yes, here.
Do you have the CT scan of this patient
No,
to know
sir.
the exact amount of bone mass which is there in a distal fragment? Because this is a X-ray where this is a case where all depends on how much amount of bone you have distally and what is the quality of bone. If there is adequate bone to fix the fracture, then obviously fixation is going to be the first option, because we wouldn't like to straight away jump, because there is no question of revision. It will end up having something like a tumor prosthesis. So do you have a CT scan to assess the quantum of bone which is there on the distal fragment?
No, sir, we don't have the CT scan. However, on the X-ray, we do see that the fracture is more or less proximal to the anterior flange. On the lateral, you can see good bone stock proximal to the prosthesis, as well as on the AP X-ray. If you see, you can see both the medial and the lateral side. There's a good amount of bone distally.
Yeah.
I have a question to Rajesh.
Yeah.
Yes.
If you have a notching, is there a particular type of fracture seen in those femoral prostheses which have notching?
So I think the very good point. The literature has shown that if you have a notch on the lateral aspect, which is a proud cortex, it doesn't really matter. If you end up notching the medial, that means now you notched both and you have a higher chance of causing a fracture.
And is there a particular pattern?
No, I don't think so. There is but it'll be something within the prosthesis or right at the edge of the prosthesis. That is the sort of a fracture you would get. This lady had no notching, and it is 10 years after the index surgery with a very significant trauma that she had this.
So usually at what period it is seen post-surgery?
So there is no, I think there is no correlation to that. And it can occur anytime from beginning to the anytime after. And I think it's like any other supracondylar fracture.
Harish, you were trying to add something?
Yeah, if this is a patient which has got, if we feel adequate distal bone stock, the fixation is going to be the first option all the time, because we must preserve the bone. She's 82. That wouldn't matter much. But if you feel personally that you wouldn't have adequate distal bone stock, because it's a postage stabilized knee, so there's going to be a box in the center. And if you have to fix it, you have to go by double plate. You have to have plate medially as well as laterally. You cannot just have one side plate and expect it to work. But usually if you do a good job of fixation, the two type medial lateral locking plate, it would work in about, I say, off the top of my head, 70-80%.
Nilen, Dr. Nilen. No, stay on the X-ray. How do you decide? How do we decide whether the implant is stable or not? Dr. Nilen Shah?
Or Mohan? Yeah, Nilen.
To decide whether the implant is stable or not, you have to look at the implant bone interface. So when you look at the implant bone interface, what Rajesh has done 10 years ago looks immaculate on these X-rays, the tibia and the femur both. So I have no doubt in my mind that this implant is stable.
Okay. Adit, can you point out the configuration of this fracture in these two X-rays? Now, or
I'm not very sure with.
Okay. Now, what you see is a large lateral condyle.
Medial.
That's medial.
Yeah, medial condyle.
Yeah.
Where your purchase of a lateral plate, that means the screw will have an adequate purchase on the medial condyle. So let me do an annotation.
Okay, sir.
You have a cursor?
Yeah. What you were trying to say, this is where the fracture is on.
Yes. Yes. So
and
this
condyle is
larger, and the lateral condyle is a smaller fragment. So probably the fracture runs from the supracondylar area like that.
Yes, sir. And it's a diagonal fracture in the coronal plate.
Yeah. Go ahead.
Yes. So I think everyone is more or less sure that we should go ahead with the fixation. The two options that we would normally have is either a lock plate or an intramedullary nail.
Go ahead.
When it comes to the plating, I think what we need to discuss is the approach that you would go ahead with. What would everyone's approach be?
Usually we should go by the same anterior approach and we expose it proximally. And when you expose proximally, you have to split the muscles obliquely, the way you extend for a long revision. And you can get adequate bone length proximally to put your plate on both the side, because if you go from the front, you can approach both medial as well as lateral. If you try to take one-sided approach, then accessing the opposite part is extremely difficult, and you leave a long area of a strip of a skin between your primary incision, which is midline, I presume, and your lateral or medial approach. So I'll go by the same approach, extend it proximally, extend it laterally into the muscle to get adequate proximal length of a femur to put your two plates. And I would insist intramedullary nail in this case is not a good option, because your locking screw will go only above the box, and quantum of bone above the box is very little to get any fixation of the intramedullary bone. I would be very hesitant to do that. If you use a bilateral plate, these are the locking plate. Even if you got a couple of screws on lateral side, which has got less amount of bone, it will still have some adequate stability there. And this would work. So my approach would be medial. Yeah.
Excellent point, Harish. And but Harish, like me, is an arthroplasty surgeon, midline incision. What does the trauma surgeon say? Sangeet or anybody has?
Yes. I would like to say, sir.
Yes, Dr. Mukhi, please.
So I would use a dual plate and put the cement in those holes, because this is osteoporotic. Even the locking hole will not be able to hold it. So you have to use cement in that void. And that bone cement will give an additional support to your distal fragment. Nail is out of question. And the shoulder plate, that is the philostrom plate, medially, and the locking plate, distal femoral plate, laterally through the anterior approach.
Great.
The nail, the problem is if you use multi-directional screw, the 3 screws, the prosthesis will not allow to pass. Because of the prosthesis, the screws will not have a purchase, or the trajectory of the screws is such that hardly you can pass 2 screws. That is a problem with the nail. And here, now, if you put it requires a dual plate if you have to use a fixation. From the lateral side, if you put a plate, you have adequate opposite side purchase of the screws. And on the medial side, you'll require a smaller plate, because even that side has a larger bone. It will be a buttress plate on the medial side, having purchased above the fracture by 2-3 screws.
Okay, let's proceed. What did you do, Adit?
Yes, so what we did was, as discussed earlier, we went ahead with the central vertical midline incision, of the previous TK. We did have a revision total knee system as standby. We did a medial parapatellar arthrotomy, opened the joint up. We confirmed the stability of the prosthesis, and then we went ahead and did a medial plating. We checked the stability under the C-arm, and then we added a lateral T-plate for increased stability. We also added an autogenous iliac bone graft. Following this, we allowed the patient to be mobilized non-weight bearing for the first 6 weeks, following which gradual weight bearing was allowed over the next couple of months. These are the X-rays at 3 months, where you can see that the fracture position is well maintained. At 1 year, you can see that the fracture has united and the position is well maintained. And this is at 3 years, where you can see that the coronal and the sagittal alignment is well maintained. The fracture is remodeled, and also the patella tracking is maintained. And the patient has a tunnel vision. She's mobilizing independently and is able to do her daily activities currently. This is a walking video at 3 years.
Excellent.
Good results.
So
only one point I would like to add in these patients. When you do the double fixation or any plate fixation, two things can go wrong. We tend to compress at the fracture site, and if we compress at the fracture site or overlap the bones to get a better bone contact, we have a much wider distal fragment and a narrower proximal, because it's a conical shaped distal metaphyseal part of a femur. So sometimes we may have a gap between the bone and a plate. The proximal end of a plate and distal end are on the bone, and in between it may stand out, as you can see here. But that is expected because you are shortening to some extent to allow better bone contact there. And number two, when you do the plate, what we can see very well is the AP alignment. That usually is not a problem, but usually in lateral alignment, you have to be very careful about aligning the flexion extension part of the distal fragment. You have done excellent job here, because it doesn't look like the distal fragment is flexed. But the commonest error is the distal fragment end up in a flexed position when you fix it. And if that happens, then again, it may have abnormal forces and it may lead to either a delayed or a non-union. So great job. Very good case.
Harish, you made the absolute point, and that is why we did a fluoroscopic check on the table, because clinically you can't make out from that incision.
No.
And you can see my plate needed to go proximally a little more anteriorly in order to maintain that. And so I think rest of the all points we've all agreed that 2 plates, midline incision is sufficient.
Rajesh.
Yes, Sangeet.
The result is excellent. It does not make any difference at the age of 85, but this X-ray shows a golf club deformity. That means the medial condyle is translated, the distal condyle is translated medially. If you see the long axis.
Yes, you're right.
So why that happens?
This is what I was telling. This is what I was telling, that when you try to compress to get better bone contact, you are fixing a broader end of a bone to a narrower end, because the central segment is compressed. So if you put one plate flush to the bone, the entire distal metaphysis shift to the opposite side. Here, the medial plate, the lateral plate is flush with the distal cortex as well as proximal. So that has pushed the distal fragment little medially. And that is the reason what you say golf club, etc. deformity is there. But the other way to do it, to prevent it, is you have to have plate which are away from bone on both the sides.
No, the reason for getting it in a normal is your plate should, like if you see on a lateral view, the Blumenset line, your plate should be ending up there. In a lateral view, you can see the Blumenset line, right? Here it is not seen because of the prosthesis. Now your plate has to end there. Otherwise, you end up in this golf club deformity in a normal distal femoral fractures. But here your practical difficulty was the prosthesis itself. You could not go anything beyond that because of the prosthesis, because the stem of the prosthesis femoral component was coming in the way.
Correct, Sangeet. I think, in fact, the distal part of the plate we had to cut with the Harrington rod and metal cutter, because that was, and we couldn't go any more distal. But I think, as Harish pointed out here, post-total knee, what is important is that you maintain coronal and the sagittal alignment of the prosthesis for a future functioning arthroplasty. if it tends to go into hyperextension, and that makes it non-functional post-surgery. But you are absolutely right. That has, and in an 85, we are okay. With it, but maybe in a younger, we are not.
Yeah, we can move on to the next.
How do you decide which plate to put first?
Sequence.
And how do you put these screws? What is the sequence of your screws?
I think the first plate is probably the where you have a more bone, where you think there is a more purchase you're going to get. Sangeet, you have a different view?
So it has to be the lateral plate first, because
for the alignment.
Then there is no design plate for the medial side.
Yes.
Okay. So
if you use the distal femur plate laterally longer and a medial philos, you will not get this deformity.
So the best implant for the medial side is a T-buttress plate where you can mold it properly.
Yeah.
Okay, Adit, go ahead and quickly summarize this.
Yes. So on doing a literature review, we found this was a systemic review done in 2015, which found that specifically for Rorabeck type 2 fractures, the union rate was comparable between lock plate and intramedullary nail. However, the complications with a lock plate were 35%, whereas for an intramedullary nail, they were as high as 53%. Another systematic review in 2020 from New Jersey found that the union rate and time to union was comparable between the lock plate and the intramedullary nail. However, the complications and reoperation rate was significantly higher with the intramedullary nail. This is another recommendation where they're recommending what sort of implant to use depending on the fracture position. Proximal shaft length stable fracture intramedullary nail would be preferred. A more distal fracture right at the tip of the prosthesis plates are definitely recommended, and any fracture between the two, the jury is still out. So the take-home message from this case was that lock plating is definitely associated with fewer complications. Always be prepared for a bicondylar plating. A midline TKA incision and a medial parapatellar arthrotomy will provide good visualization and an option for bicondylar plating via a single incision. And always consider primary autologous bone graft if required. Thank you.
Can you move to the next case?
So now I think we're moving to Jawahar, your case, if you are ready.
Yeah. Okay.
Or should we go to the, if you're going to take still?
I'm facing some technical problem with last time. It worked well, but yeah, please carry on.
Okay, so next is a spine session.
Yeah, please carry on. Yeah.
I think let's invite
we have Dr. Srivastav and we have Dr. Ingalalikar and we have Dr. Mihir Bapat. Dr. Ingalalikar has to leave a little early, so Dr. Mihir is there to be an expert panel with us. Priyank, can you share your slide, your first case to go in the spine session, please?
Yeah, I'll do that. I'll do that. Yeah. So good morning, everyone. So this is a 43-year-old female with neck pain, stiffness, and right upper limb paresthesias. Clinically, her neck range of motion was severely restricted, but she had no deficit, no breast reflexes on examination. She had a history of thyroid carcinoma metastasized to the cervical spine and the sacrum in 2014, when a thyroidectomy was done, along with a posterior cervical debulking on the right side, along with the adjuvant radioiodine therapy. The important part about the previous surgical history was that her right vertebral artery was injured during the primary surgery, as it was totally engulfed in the tumor. So when she presented, these are her images, where it shows that there's a metastasis to the C5 and C7D1 area. There is cord indentation. There is a pre-existing syrinx with some bony anomalies right from the child. The contrast shows better visualization of the metastatized part. These are the actual cuts, which shows that the tumor is there mostly in the body and in the right aspect of the lateral mass and around the vertebral artery, but the cord centrally is not badly compromised. The CT shows an osteolytic, multiple osteolytic areas, and X-rays are not really showing a lot of instability, although there's a significant kyphosis at the in the neck. Now, the thing is that this was a young patient with recurrent mets. The MRI was looking very bad. However, clinically, the patient is not that bad. There's hardly any instability. The important part is previous surgery already had issues. But at this stage also, her life expectancy as calculated by the modified Tokahashi score was good. So the question here was, how do we approach? Do we go for surgery? Do we plan radiotherapy, or do a combined approach? So these are the representative images of the patient, and I opened this case to the house.
Okay, Priyank.
Yes, sir.
Dr. Ingel,
yeah. Number one is she was operated in 2014.
Correct, sir.
Was she under regular checkup of oncologists?
Yes, she was, sir. There was a regular thyroid scan being done, and up to 2019, she was in remission. In 2020, she started showing thyroid mets, and there was a little bit of enhancement around the sacrum, around the S2 foramen.
So when there was a recurrence of mets detected in 19, was she treated for that?
So usually they were planning to do a radioiodine therapy whenever there's a recurrence, but unfortunately, whenever you do a radioiodine therapy, you have to be away from physical contact for around 3 to 6 months. The issue was that she had an infant with her, so radioiodine therapy was not possible at that time.
Okay. Second thing is, you are saying that she was not unstable.
Yes, sir. Yes, sir.
If it's a firmish mass
Correct.
occupying the whole area and engulfing broken fragments of the spine from the
Correct.
front, from the side, from above, from below, it's like enveloping a fracture
Correct.
in a cement bolus from all around.
Correct.
So the tumor mass itself gives certain amount of stability, but you cannot say that the area is not unstable.
No,
It is
sir,
unstable.
yes, sir.
It is because it slowly yields. Apart from growth of the mass within the canal, it yields.
Correct, sir. So if you see the images, there's major osteolytic area and destructions in the spine. However, clinically, the patient had zero signs of instability, primarily because when the previous surgery was done, we studied the CT scan, and although anteriorly there was a lot of instability, there was a posterior continued bony structure. So I think a non-instrumented fusion was done at that time. So that's how the stability was maintained. And clinically, the patient did not have any instability.
Okay,
Priyank,
let us move on to the case. Dr. Mihir Bapat is here with us. Dr. Mihir, what are the principles of managing this case? Now we have a vertebral body which is disappearing totally. We have a fused spine. We have a revision case area, and now the principles of management and your approach to management. How are you going to take this up, Dr. Mihir Bapat?
Yeah, so thank you, Vishal. See, this is a very interesting case. It discusses 2 or 3 points. One, whether the oncotherapy has been effective in controlling the tumor type. Now, clearly, there is a very large recurrence, and the real effectiveness of the control depends upon the medical therapy, which is not happening. Second is whether this tumor is contained or it is uncontained. Because of the previous surgery and because of the mass right now, the tumor is not contained within confines of any bone. So theoretically, complete resection is not the principle here. It is going to be palliation. So palliation of the right brachial plexus involvement because of the tumor mass and relief of pain is going to be the aim of this treatment. The central cord is not affected. Like you said, there is a posterior fusion mass. Now, as sir mentioned, if there is a threat of instability, you can stabilize it long posterior, putting in an instrument in situ. That is all you can do to help this patient. But when it comes to control of this tumor, it has to be medical. And right now, I'm not sure what this patient has presented with. Is it reflex sympathetic dystrophy because of involvement of T1? Is it brachial plexus?
So, sir, it's a C6, C7 root compression causing a lot of paresthesias. And so that was her only complaint, paresthesias in the right upper limb.
So these lateral tumors can often present with dysesthesias which are similar to sympathetic nerve involvement. So there is a definitive role of stellate ganglion blocks and palliation of these tumor while you are subjecting them to a medical line of therapy.
So I think I take it this way. Any tumor in spine simply needs only three things: stability of the spine, neurology to be preserved, and survival to be prolonged. And based on these things, I think stability here is easily objectified based on SINS scoring, which says more than 100% body is gone. This requires stabilization. So you'll have to do a stabilization procedure either from back or from front. The easier done from back here. Neurology, if this patient has no neurology, you really don't have to intervene at this stage. Just stabilize the tumor and start thinking about the survival and control of the tumor. And for survival and control of tumor, in a tumor which is already spread extraosseous, you really need to think about palliative measures rather than any definitive surgical measure. So three principles: stability, neurology, and palliative or tumor control. So based on these things, this will be my plan. Just stabilize this from behind. If there is neurology, go anterior and do a local instrumentation, either by expandable cage with plate, or if there is no neurology in that situation, just think about and with your neuro team to go and do something about the onco team to go and do something about the oncology. Here, all the vertebral arteries, in case tumor is extradural in spread, tumor is spread in the anterior lanes, you can't do much about excising this tumor completely.
Can I make a comment? Can I make a comment, Vishal?
Yes,
yeah.
yes. Please.
So first thing, Dr. Priyank, what you commented that radioactive iodine, the patient has to remain isolated for 6 to so many months. Actually, it is not. They are going to be there isolated only for 3 to 4 days, not more than that. That is one. Second, as Vishal rightly pointed out, even though there is no gross instability, it needs to be stabilized from behind. And that will protect the patient to go into any time the buckling of the posterior, whatever the cortex is remaining, and she will come with the significant deficit. So at least that part should be done, right? The debulking and all those things, I think that is going to recur. Anytime it is going to further recur and do the problem. Okay. So I think that should be the better way to approach this patient. Okay.
One important point all of us must remember. Thyroid mates are notoriously vascular. Notoriously vascular, and on the table it can be a real difficulty. And therefore be very, very careful. Since she has one vertebral artery gone, I'm not sure whether she's a good candidate for local embolization. As it is, we will not be very happy embolizing cervical segments. But knowing her one side vertebral artery is on, probably there must be profusion of collaterals, but be careful that it will be extremely vascular tumor. I remember of one such tumor where we just couldn't do anything. We had to give 15 or 16 transfusions in about 3 days' time.
Okay, Priyank, let's see what you did in this case.
Vishal, Manish has raised a hand from a long time.
Manish, please.
Well, there was only one thing which I wanted to point out regarding this tumor. In thyroid meds are very different from other meds. One thing is their survivals are very good. And second, there is a limit to the amount of radioiodine which can be used. So when you have a big mass like this, the radioiodine will not work unless you debulk it to something which is very small, so that the smaller radioiodine dose can be effective. So this is something which needs debulking. And I think what Dr. Hindlalikar said is extremely important because these are extremely vascular. And unless you can get a good embolization, it's going to be very, very difficult to do this debulk.
Agreed, totally agreed. Yeah, Manish, very valid point, I think. Any tumors, particularly thyroid, kidney, renal, anything, right? Even before touching, think twice whether you really embolize this patient or not. An embolization window to surgery should not be more than 24 hours. Very valid point, Manish. So Priyank, what did you do for this case?
So, sir, all points are actually very valid, and we had a tumor board meeting and we discussed all the points. Now, the challenges were that surgery had a very high risk because she was previously operated in the front. After her previous surgery, she had lost her voice for a month's time. Obviously, we're expecting a lot of scarring over there, plus the vertebral artery injury, and the fact that the only symptom of the patient was paresthesias in the upper limb. Also, if you look at the alignments were very bad. So the option was either we do a very big surgery where we do a front and back, realign the spine and take care of it. Because like Dr. Agrawal said, they really have a good life expectancy. Means she's already passed her 5-year mark, and the 10-year life expectancy is also more than 20%. So what we decided is we'll try to do minimal over here rather than go very aggressive. And we planned a radio surgery where we essentially did a little bit of cord clearance, which was asked by the radiation oncologist. And we put her through a SBRT procedure, which is high dose radiation at a given point of time. Now the story doesn't end here, because after the procedure, the patient did very well. She recovered her right upper limb symptoms started going away. Her quality of life improved. But then the problem started. At 6 months, the pain reappeared, and now the pain started traveling down the lower limbs. The patient started now presenting with long track symptoms. There were imbalance. There was a weakness in the range of 3 to 4 by 5 power, and she was gradually worsening. So if you look, when we got the x-rays done, this was a problem that happened. She now started developing instability at the cervical spine. And I think I know the reason why is because when we did the debulking surgery from the back, the cord clearance surgery, I think we probably let loose the tumor mass, the fusion mass, and that's where that instability happened. So this is what happened with the patient, and we got a imaging done to see what's happening. So we found a significant reduction in the size of the tumor, but with an instability at C5 now, with a progressive deterioration in the neurology, and you can see cord edema at the same area around the C5, which explains everything. So now what? This is the second part.
So
Actually,
Priyank, I strongly disagree with what was done.
Okay.
Since there is a SINS criteria
Correct,
to
sir.
understand instability, which strongly contraindicates any kind of SBRT, radiotherapy or oncotherapy measures if the score tells you that there is an imminent fracture in making, and there was already. So even before planning radiotherapy, I would rather think of stabilizing this, because this was imminent.
Yeah.
You do anything anteriorly, be it radiotherapy or definitive oncotherapy, the chances of this progressing, having a pathological fracture and neurology coming up is high there. And I would really strongly suggest stabilizing all these patients who are having an imminent pathological fracture there.
Correct. Now the challenge is how to stabilize. The patient doesn't have any lateral masses, anything on the right side. The patient is surviving only on the left sided vertebral artery. And the patient had a full fusion mass on the CT and clinically no evidence of instability. So that's where the SIN scoring, of course, gives you an idea about post radiotherapy fracture thing, but that does not cover patients which already have a fusion mass and a stable spine.
So
I think of course, we made the spine a little loose because I know exactly where I feel that the instability must have happened. But when we actually opened up the spine, the entire cervical spine, the entire from C3 to C7, there was a posterior fusion mass right over the cord.
Priyank,
yes,
even before you touched this patient for debulking from behind, you knew there is a huge bony void anteriorly and laterally.
Correct.
And therefore, the posterior so-called fusion, which to me appears very flimsy, was not adequate enough to take care of it, even if you were to leave it alone. Even if you were not to disturb that posterior mass, still this would have got into difficulty. The minimum that was required at that time is, in case I need to have an access by breaking the available fusion, I must reinforce it on the table right away there, doing what I like I want. The least one I could have done is put in hello west, hello pelvic, whatever. But this should have been protected further.
Sir, we did protect it with a customized collar, which was
No.
Yes.
The outside collars don't. It's an internal fixation, not external fixation. This case is one where you would need a bony. See, our weight of the head is not small. So it's a big ball attached to a spring at the base.
Correct. And sir, I totally agree with you, because we had given her an option of a halo jacket. We had also offered her a proper full corrective surgery. But after the discussion with the tumor board and all the surgeons involved, because it was a big team, there was so everybody, and taking the patient into confidence, because in a recurrent metastatic tumor, where the 10-year expectancy is going to be only 21%. The patient was prepared for a bigger surgery, but we thought we'll give her a smaller surgery to try and elevate her symptoms, keeping in mind that we are ready for a bigger procedure if it fails. And that is exactly what happened.
Priyank,
The SBRT controlled the tumor.
Now?
Yes. So now we went ahead and we did a bigger job, and where we again decided that of course surgery has to be done. Like Dr. Agrawal said, these thyroid patients really do well, with the oncological treatment, and with all the challenges, we went ahead and did a posterior stabilization. So the first step was we stabilized the spine from the occiput to the D2. Now the issue was, see, the right side, there is nothing where we can put any screws. The left side, in such a fixation, the only way we can really do it is by putting pedicle screws. The problem is that even with navigation, there's a chance of a vertebral artery injury, and patient living only on vertebral artery, that's going to be disastrous. So here we did a pre-operative vertebral artery stenting, a closed-ended stent, so that even if a screw touches or brushes against the vertebral artery, the chance of injuries are hardly there. And so that was the first stage where we corrected the alignment from the back and stabilized it. And as a second stage, in the anteriorly, we did corpectomies at C5 level and C7 D1 level, and put a long spanning plate, and the cages were reinforced with cement. So that's basically what we did at the end.
Okay, perfect. Priyank, Mihir, Dr. Mihir, any summarizing comments on this? How to prevent this and how to deal with it differently, Dr. Mihir? And then we close the case, hand over to Dr.
I think it's just a repetition of what all of us have said. Now, there was an impending instability which had to be recognized, and we had to stabilize this at the outset. That means before we proceed with any kind of medical or surgical treatment, this column required stabilization. So that was the first step, which could have probably prevented the later complication. I'm not sure. Second is palliation of this tumor. Now, whether you debulk or whether you do radioactive iodine or whether you do just a sympathetic block to alleviate the symptoms of this patient, the recurrence is a rule. The recurrence is going to be larger, and the life expectancies after 5 years are going to keep reducing with time. So don't try to do extravagant procedures which will compromise the functionality of this patient and give the patient a worse quality of life towards the end. So that should be the principle.
Yep. Thank you, Dr. Priyank. Thank you, Dr.
Exactly, and just yes, sir.
Yeah. So in this case, you have actually crossed the rods. Okay. And because of this crossing of rod, the C has little bit torticollis, if you see the X-ray in this patient. So you could have put the straight rod, straight on right side and left side. So that usually doesn't impart to this scoliotic tilt. There is some amount of torticollis.
Sir, I agree with you, but if I have gone back and seen her previous, like the X-rays and CTs before the 2014 X-rays, and she actually has block vertebrae, and she actually has a pre-existent upper thoracic deformity. So and the thing is that the way you see the patient over here walking, the thing is all throughout her entire treatment, she has been like this. So like Dr. Bapat said, our job was to try and do minimal and keep her this way. So that's why we took one step at a time. First, we tried to do radio surgery. Unfortunately, there was instability. Then we offered her the big procedure. We are happy and lucky that the patient walked away, and it was and it really required a lot of effort. We required an oncosurgeon because it was a very difficult case with the radiation, with all the areas taught, and all throughout the surgery we were doing the laryngeal nerve mapping, because first time the laryngeal nerve was weak. We were scared about the vertebral artery. And when a patient has been walking all throughout, we don't want to do a lot of heroic stuff, especially when the life expectancy is less. So that's why we followed these procedures in handling this patient.
How much adrenaline have you lost?
Sir.
Great. I think a lot of discussions the cases are generating, and I'm very happy about that. But that is also putting us through a little delay. I think it's time, Sangeet, that I hand over to you for the announcements, and the cases will resume after that. So spine cases will continue, but I think let's do the BOS announcements first.
So we'll have announcement followed by outside institute cases, 4 of them, and then we continue with your institute cases.
All right.
As per the plan. Swapnil will make some announcements on behalf of BOS.
Thank you, sir. Kshitij, can you please start the flash? Kshitij?
Yeah, just give me a minute.
Share screen.
Just a minute.
Which you do, Leslie, you won't come in the way, but I'll go. My internet connection. એવું કરું.
On behalf of the Bombay Orthopedic Society, we would like to thank our academic partners, trade partners for today. This is Crosslands Life Division of Sun Pharma. They have a wonderful range of orthopedic products, and they're always committed to support academic initiatives and share scientific knowledge on various platforms. Next is an announcement for an obituary, and it is with great pain and a lot of grief that we are sharing this news. And unfortunately, this is about the passing away of one of our senior members, Dr. Rajendra Jain, from Dud district of Bhilai. We may have met him, seen him. A lot of us know him personally, but a lot of us have seen him in various Bombay Orthopedic Society events in Mumbai. He was in practice since the year 1984. Very active participant in multiple symposium and conferences, has been awarded several times, has served as a president of the IMA Bhilai chapter for Chhattisgarh. A very smiling and a very gentle human soul, who passed away on the 15th of May 2021. He was working throughout the COVID pandemic, continued to work and got himself inflicted with the disease. He braved the disease and fought for almost a month with a lot of courage. But unfortunately, he couldn't be saved and he sacrificed his life while serving his patients. I would request all the members, all the faculty and everyone watching here to please observe a minute of silence in the memory of our senior member, Dr. Rajendra Jain. Thank you very much. There are a couple of announcements from the side of the Bombay Orthopedic Society. The first is regarding the membership of the Bombay Orthopedic Society. This membership is now a complete online membership where you can fill in the form online. You can suggest your referees online. You can pay the membership fees online, and you will get ratified by the next AGM. But once you have decided to become a member, you can avail the various activities of the Bombay Orthopedic Society, the various courses of the Bombay Orthopedic Society at a discounted cost. This has been decided in the last Executive Council meeting of the Bombay Orthopedic Society, that all members of the society will be able to avail the various instructional courses and the conferences of the society at a reasonably discounted cost. And hence, it is my appeal to all postgraduates, all orthopedic surgeons who are not members, to kindly visit us on www.bombayorth.in and become a member. If you have any issues with that, you can get in touch with me or the BOS treasurer, Dr. Harsha Dargikar, and we will help you out with getting you the membership. The second announcement from our side is that our calendar of events is now open. And other than the clinical meetings, the master series, the postgraduate sessions, we have almost 16 instructional courses to which members, non-members, residents, and other orthopedic surgeons across India and the world can subscribe to. The courses start in the month of July and August, and they are as follows: the orthopedic oncology course, osteotomies around the pediatric and adolescent hip basic course, the hand surgery course, the basic arthroplasty course. Research and methodology is a new course we've started this year for postgraduates, and you can avail this. Day School of Imaging for orthopedic surgeons and radiologists, again, another path-breaking course which we've been doing in the past years, is here again. The JES course, Essential Biomechanics of Implants, again for orthopedic surgeons and trainees and orthopedic residents, done by Dr. A.J. Thakur. Basic Spine course, Advanced Foot and Ankle course, Basic Fracture Fixation course, Pelviacetabular course, Basic Arthroscopy course, Technology Skills course, Pediatric Orthopedic course, and the Elizarov course. So all these courses are now open to subscription, and I would like to reiterate again that if you wish to become a member, you fill up the form and pay the subscription fees. Even if you're not ratified as a member, we will consider that, and you will get a discount when you subscribe to these courses. Thank you very much, and I now hand over the proceedings back to Dr. Sangeet Gawale and Dr. Rajesh Maniar to continue the meeting.
To add to that, kindly update your profiles. Your numbers keeps on changing. Your mail address keeps on changing, so that we all can reach you on your new phones and addresses. Second, besides the academic, we also have one event per month, which is about like one we had on finances last month. Similarly, we'll have on non-academic part once in every month. And lastly, probably soon you'll have to renew your MMC membership. Most of our courses now have 1 or 2 or 3 MMC points. Last year, if you see, we had about 30 accreditation points from all the courses. So take advantage of that and convey to your colleagues who are members. Thank you. So we start with the next session. And the first presenter from outside the local host is Dr. Mukhi. Can you share your screen, Dr. Mukhi?
Yes, sir.
And I hope our arthroplasty panel is still on. And go ahead, Dr. Mukhi. We can see your slides. Go ahead.
Yeah, play. This is a 34-year female. She has presented with pain in the right hip, not able to walk because of the severe pain, and she is brought on a wheelchair. She has restricted movements, somewhat like a fibrous ankylosis, and she has been treated for, next slide. Yeah. It's not moving. She has been treated for AKT for almost 2 to 2.5 years. and this is her MRI, which suggests that there is no cold abscess present over there, just for hyperintensities, and the cox has totally healed as per the blood counts. This is the X-ray. I want to know the treatment option. 34, tuberculosis healed, hip totally destroyed and partly protruded, and acetabulum also destroyed.
You have a CT scan to know what is the destruction of the acetabulum, the columns, anterior, posterior column, so that we can put it in which this Paprosky category it comes into.
Yeah. So we suggested her everything, and she went away from our place and got a total hip done. Yes.
Now, to do a total hip without all these things is actually not very true, not very correct.
It must have been done over there because that surgeon is a very experienced surgeon who did it. And the patient was very pain-free and she was very happy.
Harish?
We don't have the CT scan, so all films are kept by the previous surgeon.
If it is done as a first stage surgery without worrying about deep infection, because I would not do it in a one stage. I would prefer to go either debride it, open it up, take deep cultures, send it for histology, maybe put a spacer for a while, wait for all culture reports to get minimum 6 weeks you have to culture, as you know, in a difficult infection to, and especially if you're thinking of TB. And if there is any sign of infection, accordingly treat it. And it has to be like a 2-stage THR. If somebody has just gone down open and done a THR like that, as Dr. Karkhani has mentioned, I won't be surprised if the next X-ray show some amount of acetabular problem or loosening or maybe proximal migration, because the acetabular cup appears to be quite deep inside. So they may have just rimmed it a little more medially than what is advisable. So I'm quite curious to see what happens next.
Harish, I think here the AKT was given for adequate time, and Dr. Mukhi has said that the cox was on the MRI or whatever. There was no active this thing. I think the doing a THR is probably on if that is the situation. AKT fully has been given. Whether the acetabulum should have been fixed better is a different point.
Yeah.
I think I would put a very low threshold on not doing the proper analysis.
This was after 4 months.
Okay.
Sorry. Yes, Karkhani, sir.
Proceed.
Yeah, this was a good result. She was very happy. For 4 months, she was very happy. Any comments on this?
Please go ahead.
Now again, after 8 months, she started again complaining of pain.
So I think it is migrating medially. And I think the initial fixation itself is there is no rim fixation. It is only on the center. There is probably an inadequate screw fixation. That acetabulum is not stable. And I think it is now showing that it is migrating medially.
Yes.
And as Dr. Karkhani pointed out earlier, the anterior column appeared good. I am not sure whether the posterior column was as good to begin with.
Right.
I think so that we must do this Paprosky type of classification before we know what to do. For example, in this case, it has gone medially. That means the quadrilateral plate must have gone plus the columns. And probably if the patient was okay, tuberculosis wise, we have to build the medial column and then fix it on the superior column, that is on the ilium. That should have been done. Now this patient was happy for some time. She is going to be unhappy afterwards because the fixation. I think this is the first day 1 failure, Dr. Mukhi.
Rajesh.
Yes.
The X-ray which was shown post-operative, what, like you said, probably it is not it doesn't have any peripheral hold either in the anterior or the posterior column. All what it has on the floor.
Yes.
So what investigation you would have done at that time to know whether the cup has a good peripheral or some peripheral contact?
No, I think before doing the surgery, a CT scan would have given you an idea of what sort of a fixation you're going to do. Now, having already done it, you can still do a CT scan to see what sort of a cup fixation purchase it has. You could do that, but it didn't look so good to me to begin with.
Mukhi sir, go ahead.
Yeah, this was the position. She was deteriorating and she came to me. I said, you will require a re-revision. And this was after 1 year.
This was expected from the first X-ray, Dr. Mukhi, because there was distinct medial over-rimming in an infected bone, and I was expecting this. Go ahead.
Do you have a Jude view at least for this case now that it has come to you, Dr. Mukhi?
Yeah, I'll just.
You can see the columns because I think the posterior column probably is okay.
Yeah.
No.
No? So you show the Jude views if you have.
We did the CT scan and the MRI scan.
So it's too small for us to see what it is. Can you tell us what you see?
Yeah, the rim was there all around, only it had protruded in. So I was thinking that we could still go ahead with a little larger cup.
Do you have a transverse pictures of the CT scan? Mars CT scan if possible.
Yeah, it is there. Can you show?
But we need to know how much is a
Yeah, and I did the CT
column
angio
left.
also. I did the CT angio also to find out how close it was to the vessel. And I would have to call a general surgeon whether if I can safeguard the vessels in case required.
Listen. So I think the key point is that you could see that the rim was intact all 360 degrees.
Yes.
Okay, that's a little surprise, but yeah, I think that's a very that's a very positive thing. That means the initial cup was very small. The surgeon didn't really go for a rim fit at all. It was available.
Yeah. I took the autogenous iliac crest grafts and did a little jumbo type of fixation with the rim fit, and the whole void was blocked and grafted.
So that looks
good.
good.
I could get a good stability over there.
How easy or difficult it was to get that cup out, which had migrated in?
I was lucky enough, and thanks to the training of my teachers, Professor Manyar and Dr. Tarsal, that I could take it out very easily.
Yeah, the Manyar.
Harish, are you happy with the socket fixation?
It's difficult to comment only on one X-ray because
knowing
there is
that the cup has gone inside the pelvis.
No, if you use a mega cup, the mega cup has to have proper postero-inferior stability at the ischial tuberosity level and antero-superior at the anterior, near the pubic bone. If you don't have these 2-point fixed stability, the mega cup doesn't work. And the third thing, you must have dome contact. And if you don't have it, you must have to put an augment there. So unless there is a 3-point contact, it may look good on an X-ray, but it may fail because of toggling effect when the patient start loading. Medial wall, that is okay. You can put a graft and it may be there. If there is breached, it may partly go inside. People can use a mesh on the medial side to prevent graft migrating inside. But basically, if you don't have this 3-point fixation, the mega cup may look good immediately post-surgery, but end of 1 or 2 years, it will start becoming loose.
So probably a multi-hole and a fixation in the
yeah, multi-hole cup, that's correct.
Required.
Multi-hole cup was ready, augments were ready, trabecular cup was also ready, everything. But we were very much satisfied.
The only query is, why didn't you purchase in the pubis and the ischium, knowing that it has protruded inside the pelvis?
We had kept it ready. It was a multi-hole cup, but we didn't feel the necessity. The moment we put the cup in, it was holding so well that we felt that this will sail through safely.
Sangeet, I think I would agree with Dr. Mukhi that if your ream is intact and you've got an excellent purchase, then probably you got all the 3-point purchase which Harish mentioned, I think you are okay with this sort of a fixation.
It has not moved at all.
6 months is still short.
Short, yeah, I agree. But you see
need about a year,
and we can see it over here. Annotate. You can see it over here. The whole bone has found very well. and she is asymptomatic. That is the point I wanted to make.
Yeah.
And I have still kept her guarded that don't try to do all those extra activities to dislodge the fixation. It has not moved even a millimeter out of the first one. The screws are holding well. The patient is asymptomatic. I would like to take a CT scan and an MRI scan. I did support her with the AKT for 3 months post-op. That was the dictum taught to us by our bosses, that whenever you touch a healed Cox case, you must give AKT, otherwise it flares up.
Dr. Rajesh?
Yes.
In all the 3 zones, you see a lysis. Is it the X-ray picture probably which is giving that artifact, or is it something which is developing?
No, I think the concern is right, but this one looks like an X-ray picture giving that appearance. But you need to follow that up on a subsequent X-rays. I think it still needs to be really guarded, particularly. The one good thing is that the original surgeon has put the femur in a very good position.
Yes.
And I think so far this looks good. So Dr. Mukhi will present it at the next meeting at 2 years, what it looks like. Yes, Dr. Mukhi.
Thank you, sir. It's my duty to present.
I think
yes.
Can you
let's move on to the next.
I think Dr. Mukhi, it's a good case you've done.
Mukhi sir, unshare your screen so that the next person can share.
And the next case is from Dr. Devnani. Dr. Devnani, can you please share your screen? Yes, we can see you. Please go ahead.
Right. Thank you, everybody. And thank you, Dr. Vishal and Dr. Maniar, for giving me a chance to present. Now, we all are using this particular stem, the Corais uncemented stem, very regularly in our practice, whether it's primary hip replacements or even sometimes in bipolar surgery after intracapsular fracture. And to be more elaborate, most of the companies now say we have a Corais stem copy. So you have Indian companies and other foreign companies making Corais stem copies. So I thought I'd share an interesting case where I had a bit of a problem with this stem, and hope I can convey a message through it. So this was Mrs. T, and let me just put it that way, a 68-year-old lady who had a bilateral AVN when she presented to me. It was about 4 years ago. As you see, her left side on X-ray and clinically was the more symptomatic one. And I opted to do a conventional primary uncemented total hip for her. She had a Pinnacle Corail system ceramic on poly. And as usual, I have always used the anterolateral hardened type approach, which I used. On table, once I turned her supine from the lateral position, the limb length was equal. And on table, there was nothing to suggest any instability whatsoever. However, after 3 hours, I got my resident RMO in the hospital calling me that this lady has complaining of a lot of pain in her thigh, and the limb seems to be shortened. So the first thought was whether she had dislocated while transfer or whatever. But to my surprise, this is what the immediate post-op, I would say 3 hours later, X-ray showed. And so what I'm sure everybody can see here, what has happened. There has been a fracture of the calcar of that Corais stem, which has now sunk in. I was pretty sure that on table, there was no incipient fracture or anything in the calcar area while I was reaming and impacting the stem. But I really didn't understand why this happened. So here I was 3 hours later in front of the patient telling her that something has gone terribly wrong. So the available options, do you want me to present the options which I mean?
Let the panel tell us what to do.
Yeah, any available options, gentlemen, that you can offer. This is 3 hours post-operative, mind you. And what would be the best?
Can I ask you a question, Giri?
Yes, sir. Yes, sir.
Yeah. What was the size of Corais stem you used here?
The size of the stem.
What was the size of a Corais stem you used?
I think 10 or
size. The size 8, 9,
yeah.
10. It looks quite large.
9 or 10. 9 or 10. 9 or 10 is what I think.
Go back to the first
X-ray. I'm not very sure yet.
Can you go back to the first X-ray?
The pre-op?
Pre-op. That's
yeah,
correct.
Sure. Yeah.
Now, if you see the X-ray of the pre-op, there is a resolution of neck but the entire metaphyseal part and a diaphyseal part is quite widened. So there is a lot of osteoporosis in this bone. And if you have a non-cemented stem for any osteoporotic bone, this is a stem which is basically metaphyseal fixing stem. The main stem has to come in a metaphyseal part. You end up putting a much larger stem. And that to get a good primary fit, you may have to upsize the stem quite a lot, and that can cause a lot of stress. This is a case where I probably would have gone for a cemented stem, because if you try to get a very good primary fixation as you want in a primary non-cemented stem, you may end up cracking somewhere without knowing it.
Right.
So I think the choice of stem was not right. We should have gone for a cemented, looking at the proximal morphology of the bone.
Rajesh?
Yes.
This would be termed as a hoop stress fracture. And when do you think it has happened?
I think the fracture is not in the calcar, it is in the sub below the distal to the lesser trochanter, and it is very likely that there was a minor crack that happened as you were preparing, broaching the thing, which was, I know you looked for it and it didn't recognize, but maybe it was difficult to see because it is a little more distal than you expected. In 3 hours post, it has just subsided. But I think the fracture happened while preparation. And as Hari said, the stem appears quite large. You probably needed to go on with your broaching little extra.
Harish, it is contrary to what you have said. Now, you see the stem has sunk inside.
Yes, stem has sunk because there, as you mentioned, there must be a crack while preparing, because you have to get a good primary fit. So you end up putting the biggest possible broach which you get, and that has very thin cortical peripheral intact bone. So it cracks without you. It has happened twice in my case.
Crack is not at the lesser trochanter. It is far beyond that. That is why the stem has sunk down.
No, but it has to begin from the rim where you cut the neck, right? You cannot have intact rim and the implant will sink in. That crack has to start somewhere along the ring and then go down either along the calcar or below that.
Well, that gentleman was my personal feeling that I may have had a crack which I did not notice. So I did consult a couple of my senior colleagues, Dr. Bhende included, and the consensus was that we have no option but to bite the bullet and offer her a revision scenario. Now, in the revision scenario, would anybody sort of go for a same stem cemented for cost cutting, or would everybody be agreeable that we need to go for a longer stem here?
No, longer stem for sure. I think now you're left with a diaphyseal purchase, and uncemented diaphyseal stem would be my choice. I want to make a point here that do you take immediately after the operation any X-ray that we could compare this with, or
this was she was moved to the ward and a portable X-ray was asked for, but before the machine could come in, this was the complaint. So it was literally the first X-ray that I have of this lady. Right. So, you know, and it's very difficult facing the family to say this is what has happened and you require surgery within the next 24 to 48 hours. However, they were good enough and they agreed to go ahead with the flow. And this is what was done. So, which was what the whole panel was in agreement with, that we required to have a long fixing stem. Primary fixing, distal fixing stem. So I used a solution stem, wired the fracture area, which was pretty straightforward. And she progressed well after that. And she remained uneventful for 2 years from the side. This is the left side that we're talking about. She was in the interim started on teriparatide therapy by the team who was seeing her for a spinal problem. She had some porotic spinal fractures a year after the first surgery. She was put on teriparatide and she was walking with a single stick when she came to me nearly 2 years down the line for the right side, because that was also AVN, if you remember the preoperative X-ray. So this was what was the preoperative thing, and this is what I did. I was extremely careful that there should not be a crack. I was making at least 3 people in the theater check that I was doing something pretty without endangering the proximal metaphysis. And she was luckily not a problem. Post-op X-ray was fine. As is my practice in some of these patients, I tend to keep them partial weight bearing. So that's what I did for her. And she went home uneventfully at 4 days post-surgery. But 8 days post-operative, she complained of sudden onset acute right thigh pain with an inability to walk. There was clearly no history of fall. The family is quite understanding. And to my horror, this is exactly what happened, deja vu of the left side on the right side. And there was no fracture here, gentlemen. She walked on it for about 8 days before she completely sort of sat down and said, that's it, I can't do a thing. And it's a carbon copy X-ray of the left hip. So,
JD, one question here. You have already experienced that in osteoporotic bone on other side, your implant has sunk in. I don't think there is any reason to use the same implant on the other side.
Yes,
I think cemented implant would have worked very well. Number one.
That I'm coming to, Harish. That is the discussion that I want to generate.
Number two
because the whole world, the bulk of all of orthopedic surgeons now are using uncemented hips as a primary modality for even bipolar fractures in 85-year-old biddies.
That's wrong.
You know, the whole idea is to get home a point that a very standard metaphyseal, standard fixing stem, not an Indian copy, this is the original Depuy Corel stem, can do this. And I will just give you a couple of papers to support what I was saying. But yes, so this is what happened.
Girish, 1 second. The difference between the two is this is probably better fitting stem as compared to other because it has not sunk.
It has, Harish.
It has sunk.
The previous X-ray probably gives both the stems have all had lovely hold on table. I mean, having done huge numbers of these, I would not.
You understand what I'm saying?
Yeah, the sinking is similar. I would say similar, isn't it?
No. See, it is the posterior half of the trochanter and the calcar part. It has come off. If you see the tip, so distal part has not sunk. In the other side, it has sunk completely. So probably distally, the stem is holding in the isthmus part. So only the trochanter, the lesser trochanter, and some part of the proximal part of the femur has displaced.
So maybe the porosis was a bit less on this side. I don't know. And she was already on teriparatide for a year before I did this side.
No, the issue here is, can we get away only with fixation or does this require a revision of the stem?
Now this stem has sunk at the level of the calcar. You can see that. So you really cannot expect a metaphyseal fixing stem to have stability if the metaphysis has been disrupted. I mean, correct me if I'm wrong, the expert panelist, but I felt that there was no point in putting my head in the sand and saying this will settle with fixation. So I had to go ahead and do the revision as I did on the other side.
Girish, could you have avoided this by putting surplus wire to start with, having the experience of the opposite side?
I didn't find anything amiss, sir, to be very honest. When I did this, the previous X-ray, it was excellent hold on table, excellent stability. There was nothing that I felt I could achieve by putting any cerclages. I may be wrong, sir.
Yeah, can I make a comment, Girish?
Yes, sir.
If you on table feel that this is a bone where you want to put a cerclage, then non-cemented primary stem is not your option. Then you have to use cemented stem. Otherwise, you'll be putting cerclage for each and every case which you
Absolutely. Absolutely my point. The number of corails being done in this city and in the world are huge. And they are being done for patients who are partially on. This lady has, as I said, has already been on a year plus of teriparatide therapy before I did the second side. Prior to my first, yes, Rajesh.
You know what I think? Your first side, the corail was in slight varus, the stem. On the second side, it is in little more valgus and probably a rotation. And I think that could have predisposed loading the medial side. If you do an uncement in a wide canal like what Harish was trying to point out, we're just trying to think aloud. I'm not, the canal needs to be completely purchased. If a proximal part is porotic, if probably that did not happen, it would continue to sink and load medial side. That's what has happened.
Now, in interest of time, can we move on, please?
Girish, can you summarize? Have you done something for this case? Can you move ahead?
Yeah, this is what I did for this case. Same thing as I did on the opposite side. Now she's now 2 years post-operative. She's ongoing osteoporosis therapy is maintaining with denosumab now. She has no complaints. I'm keeping my fingers crossed. I've just 2 minutes. If you give me, I'll just share some literature which supports this concept.
Girish, we are late.
Yeah.
Sorry. Thank you very much.
Okay.
Excellent case. Manish,
Thanks.
can you share your screen?
In the meanwhile, Dr. Mukhi, Dr. Girish, can you just go on YouTube? There are a few questions coming in from Dr.
I will.
Pawar.
Yeah, sure.
Thank you. Please answer.
Thank you. Thank you.
Girish, unshare your screen.
Yes. Doing that now, sir. Yeah.
Manish.
YouTube. Many questions coming.
So while Dr. Manish Agarwal comes in to show his prosthesis, I'll tell you this is one of a kind designed by an Indian, and this is one of the world-class prosthesis that is going to be seen now. It has been designed by the mind of BOS in consultation with the IIT technicians and technology guys involved into this. So we must congratulate Dr. Manish Agarwal for what he's going to show to us now.
Well, good morning and thank you for this opportunity. And I must tell you that this is the first time I'm going to be presenting the results of what we've been implanting now on a clinical trial. So this was a 28-year-old male, osteosarcoma, distal femur. He's already received 2 cycles of chemotherapy outside before he came to us. A very large tumor. You can see the huge bulk on the posterior side, but there's a plane between the vessels and the tumor, so we were able to get this off. This is an intraoperative picture showing you the tumor, a standard resection of the distal femur. That's what the tumor looked like. This is the prosthesis, the tibial component, the femoral component. This is the articulated implant which has been put in, just to show you what it looks like. And these are the post-op X-rays.
Yeah, it's too short.
Now this is a 2-year follow-up.
Needs to be wider. You always want to load the metathesis completely.
Again, just to show you that the results are very similar. So what's different about this case? I think we all know that we do distal femur prosthesis, but this is an implant which has been completely designed as well as manufactured in India as per international standards and benchmarked against the best of the implants. And I'm just going to show you how it differs from the other implants. So this whole effort actually began when I joined TMH in 2000. Initially, we had these fixed stainless steel hinges. These were customized. These were not modular. In 2006, with the help of Sushrut, we converted these into modular fixed hinges. Most of the components were stainless steel. But we knew that these are a problem, these are going to fail in future. You can see here the bushings wear out and then the axle breaks and there is metallosis. So, I mean, right from 2003, we started work on this particular implant, initially involving IIT. We have Professor Ravi here, who's logged in, and you can ask him the questions about how they went about designing it. But we started the work, and Non-Ferrous Technology Development Corporation from Hyderabad, which comes under the Ministry of Mines, Government of India, but is not funded by them. They generate their own funding. So there's a lot of answerability, and they do all big projects. They joined us in this. We put in a project. It got funded by the Principal Scientific Advisor's Office, Government of India, with only one condition, which Dr. Chidambaram told us, that it must go into the body. It should not remain in the labs. After 13 years of effort, all that came true. I'm just showing you some pictures of the initial design. There were lots of designs, and we were never happy with one. We had to be original, and we had to pick up a design which is going to last. So a lot of modeling was done, designs were made, changed. Finally, we've got this one, and this is what the prosthesis looks like. It was not enough to just design the implant. It was very important to test it first before it went into the body. And this would be very different from any other prosthesis of Indian make, which we have done so far. So it was first virtually tested. Then it underwent an actual physical testing of 20 million cycles on a knee simulator. Now, this wasn't easy because we had to even make the knee simulator, and that is where the NFTDC came in. We have Nirmal Panda here from the NFTDC, who's been involved right with this project here. And once it went through all this testing, we had all the benchmarks. We checked how much is the wear on the poly components and whether they were lasting. We found it was okay. Then we approached the drug controller for the clinical trials. Now, in addition to the implant, we've made these jigs. This femoral jig is completely new. It does not exist in any other international system. It's also got the patent now. We've also made the tibial jig, made it simpler than what were existing. These are intramedullary tibial cutting jigs, and this is working quite well. These are just some pictures from surgery. This is the femoral jig. That's the tibial jig. That's what the implant looks like. And this video is just going to show you what is the way in which it is manufactured. I mean, the machines which are used for this particular implant are exactly the same used by any international company. You've got a 5-axis milling machine. The CAD/CAM programs which are used are similar to what is used anywhere internationally. So, I mean, first our engineers had to master how to program these machines, make it. This is a robot for the final, what is called a super finishing, to give you that glass finish or the mirror finish, what is known. The tolerances have to be very good. So they're measured with lasers so that each component can fit into each other. Most important part, the poly finish has to come up again with the international standards, because that has been the weak link before. And we also developed the full technology for HA coating, which was required on the collar for extracortical bridging. So as you can see, we took on a lot on our plate, but fortunately we were able to do it. This is just a schematic. And what is the most important thing is that there is no such hinge existing anywhere in the world. So if you look at this, this gives you only 5 degrees of movement on either side, exactly like the normal knee. The axis of rotation or the center of rotation is exactly like in the normal knee. It comes within the joint. It's not on the tibial plate, like you will see in the further videos on the other international joints, where the whole tibial component base plate moves on the tibial poly, and that's what gives you the rotation. Now we've also changed the stem to make it a 2-part stem, as you can see here, because we had done our testing studies. It was done in South Africa, and it was shown that for the narrower stems which we use, the 2-part stem has much less stress at the collar stem interface, and therefore they were less likely to break. So this is what we've used in our design. Again, we made sure that we had better modularity than what even the Stryker GMRS has. In the GMRS, you don't get a 12 size stem. From 11, it goes to 13, then goes to 15, but we've got everything in 1 millimeter increments, right from size 8 to size 17. So you can see the pictures of all the 3. This is clearly superior to what we were using, which is the modular hinge, because it's a rotating hinge. It's also manufactured with the best methods. And the GMRS is the benchmark. Again, you can see GMRS has a rotating metal hinge which rotates on the tibial poly, like our joint. So this is a video showing you, this is the rotation that you see in our prosthesis. And then you'll be able to see the rotation in the tibial. You can see in the GMRS how that rotation is complete. Now, the advantage of restricting the rotation is that the patient is a lot more stable when they are walking till the time the quadriceps power comes, because we always lose some amount of quadriceps when we resect the tumors. And therefore, these patients walk much better, much quicker as compared to what you have with the GMRS till the time the quadriceps power comes in. Also, our design locks in extension, so gives them a lot of stability when going upstairs or climbing downstairs, which is not there with the GMRS system today. Again, this is the only joint which actually is load sharing the weight transmission between the tibial poly as well as the hinge. Every other joint has got all the load which comes only on the hinge. And this is probably the reason why this joint wears out much lesser on the hinge side. So I'm now going to just let the whole panel give their comments, their suggestions. We've already done 7 cases. The one which I showed you was the first one, and we have a 2-year follow-up of this. This is now going to open up in Tata Memorial Hospital. Of rupees, which is the same as what we are using for the fixed hinge today, and it's completely made in India, and it's not done by any commercial manufacturer. It has been done by our academic institute, so that's what's different from this.
Manish, you have finished your presentation, so unshare your screen. Any questions?
I think excellent work. Really, the question is, Manish, that with the rotating platform for the primary and some of the other revisions, we know that up to 10 or 11 degree of rotation is a good thing. And having a rotation at the under surface, yours is not at the under, it is at the superior surface, which will actually lead to more polywear. So these are the two questions. One is that the amount of rotation, if you restrict, you're going to put that much more pressure on the fixation. And the second is this rotation occurring at the proximal surface is going to lead to wear.
I've lost the last part. I couldn't hear the last part.
So the one is that if you restrict the rotation to 5 degrees in at least the primary mobile bearing and the revision mobile bearing, we know that you need up to 10 or 11 degrees. If you don't, you're going to put pressure on the fixation. That is one. And the second question, having a mobility at the proximal surface rather than the distal, you're going to increase the wear where the contact is not as good as at the undersurface.
Yes, so that was the main reason why we did the simulator studies, Rajesh, and they did not show the wear, even on 20 million cycles of loading. So actually the amount of rotation that you need is just to make sure that you don't face too much of torque at the stem cement interface. And the 5 degrees on either side is actually giving you 10 degrees of rotation, and that's generally enough. Even the fixed hinges actually have done well in the long run. If you look at the HMRS joint, which was made by How Medica initially, the long-term results have been very good, even with the fixed hinge. Only thing is that they used to cause a lot of bushing wear because they were fixed hinges. Now, this particular thing we have already tested on the simulator and shown that there is no real excessive wearing out on either the hinge or on the tibial tray. But the results in the real body can be different, and that's the reason why we are also on this. So hopefully we will know over a period of time. We are also going to be doing the gait analysis studies to see whether the gait with this prosthesis is anything which is objectively different from what we were seeing with the GMRS striker, so that at least we can then understand whether biomechanically changing this center of rotation has really made any difference. So I'll get back to you once I have those results.
Excellent work.
Manish, we are short of time.
Yeah.
Thank you very much. And only two issues. What is the longevity of your cases done and what is the price?
Well, I already told you that the longest follow-up of the trial is now 2 years. And what we have learned from our past experience is that when the prosthesis has not failed in the first 2 years, then generally it would last at least 5 years. And then the failures which come are coming from the bushing wear. So the breakages which used to happen in the first 2 years, the stem collar junction stress breakages. Now we will be following these patients up for a longer period of time, but this is clearly better than what we were using currently. And therefore the plan is first to substitute what we were using with the Indian one. The cost of this is actually cheaper than the current Indian fixed hinge prosthesis. And the imported one actually costs 4 lakhs. So there's a huge cost difference because of not being passing on this technology cost to the patient. I mean, this has been absorbed by the government through the development costs on the project.
Dr. Mukhi, you can ask the question on a personal chat. We are short of time. Manish, we all appreciate your efforts. Thank you very much.
Thank you.
The next speaker is Dr. Rujita. Can you share your screen?
Is it visible?
Yes.
Okay, so this is going to be a very quick, short presentation of a BOS case follow-up. This case was presented at the clinical meeting of Wadia Children's Hospital in 2017. It was a very, very unusual radioulnar synostosis. A 14-year-old boy with a left forearm deformity, very well adapted to daily activities, but extremely keen on correction of his deformity due to a severe social stigma. So the challenges in this case were huge because he had a hyperpronation deformity of about 180 degrees. It was like we would need to mirror the forearm back into a normal rotation. He had 0 rotations at the pronosupination level. The elbow range was good, wrist was good, but there was a weakness of the grip due to the flexors being wound around the forearm in a very twisted manner. However, he had reasonable good hand functions, and when we examined him, we saw that he had additionally a hypoplasia of the entire left hemithorax, which meant that this was a syndromic radioulnar synostosis. That's his function of how well he was adapted despite his deformity. So we were also worried that if we do correct this, will he ever regain his function? So we should not end up treating an X-ray and disable the patient. But with these challenges, we decided to present this in the BOS. These were the X-ray findings: the proximal radioulnar synostosis with an overriding of both the bones. The radioulnar variance was lost distally. And there was a dysplastic and posteriorly dislocated radial head type 3 Cleary and Omer. And hence it was not going to be easy to correct. There were going to be challenges with the fixation modality and how much to derotate. But since the negative body image really needed correction, we decided that ultimately about 120 to 130 degrees correction would be enough, but it would still be technically challenging. And hence what investigations to do and what method of fixation to choose, and whether to do it in 1 stage or 2 stage with possible complications is what was discussed in the BOS at 2017. After the opinion of the House, we decided to go ahead with a 3D model, and that is what it showed, almost like a DNA double helix with absolutely no symmetry of the diameters or the surfaces anywhere on the bones. So we decided to treat it in 3 parts and try to align part 1 with part 2 first and then part 2 with part 3. Literature showed the 3 largest series that the average max correction in any of these series was about 80 degrees at one go. However, it was fraught with a lot of complications, almost 12%, which is a huge rate of neurovascular complications. Yet another series from India, of course, in very simple radioulnar synostosis, where the average correction was 87 degrees, but it was a double level osteotomy. And this is the concept that we borrowed and we decided to apply to our case. There are other methods by using Elizaro, but they included a very huge complication rate. And hence we decided to go ahead with an angiogram, which showed a very poor distal vasculature. So we then called our plastic surgery colleagues in, and at the first stage decided to do open it up and have a huge incision, identify the pedicle. Only if the radial artery permitted, then we would do osteotomy of the radius and ulna at 2 different levels. And we decided to use a ESIN, intramedullary fixation with a nail. So that's the incision which was pre-planned before. I will not go into too much details here, but as you can see with this incision, that's the pedicle that we have seen distally tapering down. But the vascular surgeon was the opinion that this was of good capacitance, and hence we went ahead with 2-level osteotomy, fixed it with the ESIN, as you can see here, and brought it only to a different level of supination. Now that's the radial osteotomy, and that's after the ulnar osteotomy. And that's the kind of fixation that we had done. At follow-up, the child was quite comfortable. He had rotated only at about 90 degrees. And after about 6 to 8 months, when he had adapted at this, then we went ahead and did the 2nd stage correction. And that's now him at his 4-year follow-up, very well adapted, doing everything, able to dress himself, still retaining absolutely the same amount of function that as was before. So the point to present this really was that if you really plan it well, stage it out, and collaborate with your colleagues, chances are that you will be able to reduce the complications and get a good result. Thank you very much. I will be appreciative of any comments and critical analysis.
Excellent. Alric is on this panel. Alric, are you there?
Yes, very much. Well, I was part of this case as well, so won't be right for me to comment, except to say that, I think the main takeaway message from this case is when you have a complex rotational problem like this, the pre-op planning is extremely important. And we spent a lot of time thinking through this case, did the pre-op angiogram, and I think what was really worthwhile was the 3D printing. That model helped us a lot. It really shows how technology can impact nowadays proper pre-op planning, because that gave us a good sense of what exactly this complex deformity was, much more than what a CT scan or any other investigation would do. So a case well managed, Rujita. Thank you.
Tushar, I mean, your experience on this?
I just want to ask, in a simple case of radioulnar synostosis, 7-year-old boy, would we require to do the same amount of planning, or can we do the standard procedure which we are doing?
I think, Tushar, we can go ahead with the standard procedure in that. If there is no twisting beyond 30-40 degrees, then you don't really need here. There you can do the standard ulna higher, radius lower, double level osteotomy. But here, since no plate would have held, Elizaro would also have compromised the neurovascular bundle. Therefore, after the 3D planning, what was obvious to us was that the only choice is a TENS or a ESIN nail, which would be flexible enough to rotate and turn along with the deformity that we were planning to correct. So that was the only message in this case.
So we conclude the 4 cases from outside the institute, we go back to the host institute, Dr. Rajesh.
Yes, thank you, Sangeet. Vishal.
Yes, sir. I'll share my
So
screen.
next case is yours. And can you please share your screen?
Yeah, so quickly running through and changing the gears back to spine. May I also have a panel, Dr. Srivastava sir and Dr. Mihir Bapat here, apart from other spine team guys here. This is a case of high-grade spondylolisthesis in an adolescent male who's symptomatic and progressively getting symptomatic, turning off the feet. His posture is also having very typical findings of a palpable step, has very limited lumbar flexion, and everything being okay in terms of neurology, but he's still not able to play his favorite sport, football, because he gets pain even if he walks for 10-15 minutes in his buttocks more than any in the legs. And these are his x-rays that he brought with him. And these are the dynamic views that we generally tend to do for any listhesis to check if there is any mobility in there. And with high-grade listhesis level 4 and a vertical sacrum, of course, the options of conservative treatment are already burnt out in this patient. These are the CT scans showing the challenges that often we see in dysplastic high-grade adolescent listhesis, a dysplastic L5 pedicle, as you can appreciate here. The sacrum dome is seen here. And of course, we can see the high-grade listhesis, which has very, very little mobility even on the dynamic films. That's the kind of MRI where the sacrum hibernation of the sacral dome is seen, and you see a trapezoidal L5, a dysplastic pedicle. So with all these challenges, a vertical sacrum, I'm sure everybody would agree that conservative and bracing is surely out of question and surgery is the only option. And these are the options in my mind. Let me have my panel here to help me to understand if we need to do a complete reduction or a partial reduction, and should we do a L4 to S1 fixation or a L5 to S1 fixation. Dr. Mihir Bapat, and then followed by Dr. Srivastava's comments on this.
Right. Am I audible?
Yes, very much.
Thanks, Vishal. Excellent case. L5 is dysplastic for sure. It's going to mean a very poor purchase. I'm also going to measure my L4 screws. If you see the L3 and the L4 also looks a little more dysplastic as compared to the L3. So you have to be very, very careful with these pedicles. And in this case, particularly L4 to S1 is a better option for sure.
Perfect. Dr. Srivastava, any difference in your opinion and any challenges that you think or anticipate during this case?
Yeah, so in this case, having hold on L5, one has to be little critical. So what usually I do with the small opening, use the probe and use the very thin diameter, tap and gradually enlarge it. So the hold of L5 is extremely important. Right from the beginning, positioning of the patient, you should hyperextend the hip. So in that case, the partial reduction you can achieve nicely. Then you have to chisel off the dome of S1 to have your reconstruct nicely there. So these two important things I would like to point, which makes the surgeon comfortable during surgery.
Perfect. So wonderful tips about reduction and super comments about instrumentation L4 to S1, like Mihir said. I'm sure everybody will agree. Dr. Ramchada, can I catch you on about what are the problems what a surgeon should anticipate intraoperatively and postoperatively to avoid any problems in this? Dr. Ramchada.
Well, problem intraoperatively, one, we must understand that most of the patients after proper positioning, even intraoperatively, will look much better than your preoperative x-rays. So you might get carried away in changing your decision from a 4 to S1 to a 5 to S1, but that may actually be a little bit immature in this situation. Next, you have to be prepared that in these patients, these are usually congenital presentations to a large extent, and there may be other root anomalies which have to be looked for. Hence, placement of your implants, especially in these hypoplastic pedicles, are fraught with dangers, and identifying all the roots before placement of the implants, especially the L5 pedicle, would be a part of my surgical exposure.
Right. Priyank, you are the new generation guy here. Priyank, would you depend on segmental fusion L5S1 only, or you would also take it up to L4?
In this case, I would take it up to L4.
Like all other high-grade listhesis, you would stop at L5S1?
No. So high-grade listhesis, this types. So depending upon the classification, the type 5 are the ones, 5 and 6 are the ones where you would want, especially 5B is where you want to go to L4, and this looks like that.
So Dr. Mihir,
the
let me catch you on
SDSG
this.
classification.
Yes, perfect. So I think the house is divided where sometimes you may end up doing only L5S1, sometimes you may want to go L4. Dr. Ram said be prepared for congenital anomalies. Dr. Srivastava mentioned about the positioning intraoperatively and a wide release of the disc and facetectomies and seeing all the nerve roots. My question is, have you always been doing only L4 to S1 for high grade, or now with interbody cages and with better preparation devices, L5 S1 only segmental fusion with complete reduction is also an option?
So in most cases, if the L5 pedicle is good and it does have a good pull-out strength, L5S1 is good enough. And with the modern things like navigation, and you can direct your screws better, you end up having a better purchase on the L5. So that allows you to put a snug fit screw there, which allows you to keep your instrumentation limited to L5 to S1.
Right. And what do you anticipate can happen intraoperatively? Anything that can go wrong, or post-operatively?
No, I think most important, if you get your screws in, then the next focus is on your L5 nerve. That means you have to ensure that your L5 nerve is under vision as you sort of gradually stretch the spine back into position. And the L5 nerve should be quite lax and relaxed by complete decompression when you're doing it open.
Perfect. So I think I completely, yes, Dr. Ram.
I would like to say that my placement of the L4 screw, whether it's an implant or an intraoperative instrument, would be decided during the surgery.
Right.
If I'm able to get some good end plate to end plate positioning and a good anterior interbody reconstruction with a good implant in there as a spacer, and I can correct the kyphosis very well, yes, I may try avoiding impaling the L4-5 area permanently.
Perfect. Dr. Sudhir, we have seen you having run through an era where in situ fusion for such high grade with a delta fixation also does exist. And it is also written in books, it does exist even now. So how much reduction is actually needed now? And is it really needed? Can we not do in situ fusion in these cases? Why reduce at all?
No, actually, see, here the why reduction is important to have a interbody graft. That is the one thing. Biomechanically, it is better. Now, as Dr. Ram already mentioned, it is the slip angle which is important. So you have to correct the angle nicely so that your biomechanical alignment improves. So it is not the degree of slip, but the slip angle. And for that, the prerequisite that you should have a far lateral, opening of the nerve root so that you have a far lateral dissection to reduce the chances of neurological deficit. So I will not be in the favor of in situ fixation unless your alignment, it doesn't matter much if your pelvic incidence, those criteria fits into, and where you can do fibula grafting from S1 to L5, only in those situations. Otherwise, I would always try to improve the slip angle, and whatever the slip degree, staging improves, I will accept that.
And so I think I totally agree with all the comments that you have given, and having learned from you all stalwarts here and continue learning from my younger colleagues like Priyank, I did the same thing in this particular case. My plan was to use L4 as an intraoperative measure to reduce L5. Plan is to do at least partial reduction, correct the slip angle. The kyphosis of L5 has to be reduced, even if the translation doesn't comes back to level 0, level 1, but at least the kyphotic angle has to be reduced. And I plan to do a L5-S1 fusion. Positioning was like what Dr. Srivastava said. Decompression of nerve roots was like Dr. Ramchandra said. Neuromonitoring to monitor the L5 while reducing was done in this particular case, like Dr. Mihir mentioned. And I used a L4 screw to get my L5 back, did a bilateral facetectomy, bilateral discectomy, and got my good reduction there. And as Priyank mentioned, I tend to use L4 only for intraoperative measures, and that's my post-op X-ray. So everyone agrees here. Any difference in what you would do, Dr. Mihir, Dr. Sudhir? And it's a rock solid screw there. I have used navigation, which I've been using so often now. It's a 6.5 by 45 screw in L5 and 6.5 by 40 screw in S1. Quite solid hold, superb convergence in there. Anything different, Dr. Srivastava, Dr. Mihir, or Ram would do?
Yeah, here you see, Vishal, you have got the good thing, but here if you see the sacrum is still vertical. So I have a little, doubt about in follow-up if you are going to have problem.
Right. Dr. Ram, anything different other than this?
So the only thing which I would say is that, see, with these cages where we can't see what the cages look like and what exactly is the hold, it's a little bit difficult to comment. If I had all metal expandable cages, and in this particular situation, I might do even a P-lift, which Mihir and I have been doing for a long time from both sides to get that good anterior interbody purchase with 2 spaces and a lot of graft. I probably would protect my posterior implants better.
Right. Mihir, anything different or anything less we have done here?
No, I would be very scared in removing that L4 screw which you have done, because this pedicle is dysplastic. That means that you may feel that it is rock solid because your L4 has helped you in getting that reduction. So your L5 screws look good on table, but I am very scared of keeping this severe deformity only on a dysplastic pedicle.
So is it a blanket statement for all cases? Always go from L4 to S1?
See, when you have small dysplastic pedicles, there is no point taking risk with the L5 because your whole surgery depends upon those 2 screws. And
wisdom belongs to wise men. Mihir, wisdom belongs to wise men like you. I was not so wise enough when I did this case. And unfortunately, despite having a superb, uneventful course for almost 6 months, it was in the 8th month when patient comes back to me, totally asymptomatic, but with slight tightness of his legs that running karte waqt pair mein abhi bhi bhari lagta hai. So this is his X-ray now at 8 months post-op. What is happening, Dr. Mihir, and can you highlight why has this happened? It's only because I missed the L4. Patient is asymptomatic. He's got no complaints, but he is here. So my question is, this is his CT scan. This is his X-ray. He's got totally no symptoms. Flexion, extension movement show absolutely no movement at that area. Implant looks in place, still holding. As you can see, L5 and S1 both screws. There is no lucency around the screws. The cage is in there, almost at the verge of fusion. But the trapezoidal L5 and S1 both, they although looks fusion, but it is worrisome. So my question is, why did this happen? It is because of short construct that I had, or is it because of the cage subsidence that happens in T-lift? Is it because inadequate hold in L5, or is it the beginning of pseudoarthrosis? Dr. Ram, Dr. Mihir, Dr. Srivastava, over to you.
I think it's a combination of all. Please understand, what is easy to reduce is very easy to subluxate again. So what you manage to get, and I agree with Mihir totally, probably in this patient, we could have gone longer, counseled the patient that once you're fused, then we'll unlock your 4-5, like Jürgen Harms used to do. But as I said, we've learned a lot that this is somewhere we've gone wrong. As I said, I'm not too sure whether my interbody was strong enough to allow me this.
Dr. Srivastava sir, what would you do to prevent this from happening in your next case? Like I should do, what I should do to prevent this?
Yes, I think holding on the 4 is important. Another thing is the biomechanical alignment. Now you are lucky that you don't have any fracture between S1 and S2, because that is the another thing which happens in slightly osteoporotic spine. It gets fractured from here because body always try to get the biomechanical alignment. So intra-op, we had seen the sacrum was very vertical. Okay, so usually it tries to come forward and there is a fracture at S1 and S2 area. Though radiologically it is looking that it is healed, and if it is healed, then it will fracture at S1 and S2. So that is the thing
what to do next now? Patient is asymptomatic. The listhesis has gone back to grade 2 already from grade 4.
I think Vishal, this is going to evolve. That means that we have to be very lucky at this point to assume that it's not going to evolve. Now, option 1 is to keep observing till the patient develops a complication, or to act on it right now. So if you want to act on it, you have to span these implants and take your L4 and put your iliac screws and protect this whole construct in a proper way.
Right.
Well, before
Dr. Ramchadda comes in with his slides, one final comment from the house. Dr. Sangeet, Dr. Vinod Agarwal, Dr. Kshitij, you are all there. You have been managing all these cases. What is your take on high-grade spondylolisthesis? Will you always use L4 to S1? Will you always reduce them totally? Or you would continue doing partial reduction, always L4 to S1, and try not to reduce them fully?
Vishal, it is Vinod's case next. It is Vinod's case next.
Oh, yes, we can have Dr. Vinod's case next coming up. Dr. Vinod, share your slides while the answer comes up. Mihir sir, last summary statement from you.
No, I think this case highlights the importance of measuring your L5 pedicle and really gauging whether you can keep your fixation short. As surgeons, we like to keep it short, but it is wiser to take the L4 if you have even the slightest doubts on your L5 pedicle when a listhesis is more than grade 4, because the deforming forces are extremely severe. It's the bottom of the pillar, and that needs to be the strongest when you fix these deformities.
I think it's a summary of the case that high-grade listhesis is, though uncommon, is a very challenging case. Reduction is something that is mandatory to get good fusion there. Try to reduce partially rather than fully. Reduce total amount of kyphosis, but translation necessarily doesn't have to come back to prevent any L5 injury. Also, something that comes back easily will go back easily. Try to have a L4 purchase, particularly when you have a dysplastic L5 or dysplastic L5 pedicles, or you're using short screws in the L5, and try not to have a cage which can subside more by having end plates prepared just optimally there. Dr. Vinod Agarwal, may I invite you to bring your case, and let's move on to the case which is Cox spine here.
Vishal.
Yes, sir. Harkani, sir.
If Vinod is not there, let Ram go ahead. Ram, share your screens and Vinod can present after yours. I'll speak
Dr.
to you.
Karkhani, sir, your comment, please.
Ram.
No, I was just asking you whether the literature says that you don't have to take L4 in such cases.
Yes, sir. Yes. Now, in fact, after this case was done by me in 2013. After this, I have done 10 of these cases and never I have used L4. And this was the only case where I regret. And what really led to this failure, nobody knows. These are all assumptions, whether it is osteoporosis, whether it is end plate preparation, or whether it is a less purchase of L4. But generally, my blanket rule is in young guys with dysplastic listhesis.
Vishal, I think we've had long discussion on this. Let's move on, please. Ram, please go ahead.
72-year-old gentleman who has presented with unresolved back pain for the past 15 years, worsening claudication and back pain for the past 3 months, sudden onset buckling of the left knee, some weakness in the toe with early foot drop for 3 weeks, seen by me about 16 years back. I want an opinion from the house. These are his x-rays. AP lateral flexion extension, lumbarized L5 with a mobile 4-5 listhesis with a vacuum sign seen. Any comment from the house?
Dr. Bapat?
So, Ram, I think we have had a fair amount of conservative trial over 20 years, and the patient clearly seems to have deterioration of his function. If clinically he is getting more and more disabled, we need to evaluate this further. It's an unstable listhesis.
Thank you so much. Patient now willing for surgery, and with the onset of neurology disabling him, he has decided to listen to us. And after thinking and counseling him, we get his MRIs done. His MRIs show, as very clearly seen, an L4-5 listhesis. He also has a left-sided L3-4 synovial cyst with fluid-filled facets. We are looking at surgery. Opinion of the house for surgery planned.
You would definitely take a neurology opinion and an EMG as well before actually going in for the surgery, to see if there is any other reason that this could be a neurology. I mean, ruling out a non-spine cause.
Okay, thank you, Swapnil. We appreciate. Neurology opinion and EMG say that it is related to the nerve roots and it is related to the spine.
Sir, if I may.
Yes, please, Priyank.
Sir, everything fits into picture. There is 2-level significant stenosis. At 3-4, there is the acute facetious formation, which matches with the left-sided deficit. So this patient requires a decompression and a stabilization surgery, and that is what I would plan for him. From 3 to 3, 4, 5, including all the 3 levels.
So you're going to, what is your surgery, Priyank? Are you planning?
Sir, I would plan a wide decompression with a posterolateral fusion from 3 to 5.
Instrumented.
Yes, sir. Instrumented fusion. Yes.
Okay. May I go ahead? Well,
yes, sir.
This is the synovial cyst and the listhesis, which I'm just showing you. I share with you that after some thinking, counseling, we decided that he's a 72-year-old gentleman and we should do what worked best in our hands in the year 2004 or 5. So I decided to do a 4-5 solid decompression instrumented fusion and did a 3-4 decompression for the synovial cyst and just put in a flexible rod from 3 to 4, which means that I solidly fused him and allowed no movement at 4-5, but I allowed physiological loading at 3-4. Contrary to my plan and hope, this patient came back 3 years later with symptoms and signs more proximal to his primary pathology radiologically and clinically, which means he had developed a symptomatic adjacent segment disease, was finding it difficult to walk and getting off the chair, although he was having well-controlled sphincters. What do we do now? We are now 3 years down the line after a grateful, successful surgery the first time. We have options like 1, decompress alone. Next is decompress and stabilize. Third is anything else that may come to your mind. Inputs from the house.
Ram, have you done the flexion extension view in this case, and it is stable, you feel?
Yes, there is flexion extension view. It is not stable. There is an element of prolisthesis, like a degenerative listhesis at the level above. You are absolutely right, sir.
Yeah, so in this case, if we wish to do any procedure, and that would be actually directed towards the neurology or neurological symptom, then I think fixation would be essential. So if he is symptomatic enough, not able to walk, has significant, neurological claudication, and he has started further some deficit-like thing, or he has instability phase, again the same thing. It usually it does happen that proximal to the fixation site, again patient comes with stenosis and he becomes symptomatic. I think one has to extend the fixation, and that is important.
Dr. Srivastava, this is exactly what I thought. I was unhappy that I'd used a flexible rod and this still happened. That is what hurt me at that time. So what would you do now, sir?
We'll have to change the rod, go proximally, put a screw and decompress at that area.
So you are going one level above, yeah, and you are doing a decompression stabilization. Am I correct, sir?
Yes.
Okay. So we did that as per Dr. Srivastava's suggestion. There was a stenosis at 2, 3. We went to the next level and we did 2, 3, 4, 5 stabilization, converted the flexible rod, this partly flexible rod, into a solid rod. And if you notice, now we've done posterolateral fusion at the 2 levels which I had not fused earlier, the new one and the previous one. Any comments on this? Are we okay with this? He's now about 75 years old.
And I hope on the front of osteoporosis, you might have given other medical treatment of that.
Sir, I love you so much. Sir, his wife had an osteoporotic vertebral compression fracture. She was started on teriparatide for 2 years. She did very well. So he said, Doctor साहब मुझे भी लगा दो. I said, sir, अभी नहीं लगाना. आपकी उम्र में इस आदमियों को नहीं होता. So I didn't give him teriparatide at this stage. This man lived well for another 5 years.
And had about.
He came to me 5 years later, which is now 8 years from the index surgery, where I had done an L2 to L4 posterolateral instrumented fusion over an old L4-5 fusion. I went through his records. This is what I had done till now, and I had learned that adjacent segment disease exists. And I was very proud that I had treated it well with a very good solid construct. However, 5 years later, what happened? Well, the disc across the instrumented level settled down. The disc above it settled down and the screws started backing out. Dr. Srivastava's prediction was working. The bone quality had diminished in this man as well, and he had pain. He could not get up from bed and was now feeling very weak around the hip region as well. This is what he had now. This disc had also popped out all of a sudden. What do we do now, sirs?
What we have always been doing. Don't get confusion, just add fusion.
We have now already reached thoracolumbar junction, Vishal. Where do we go now?
No, it's only one level higher. Degeneration is a fight. It's a race against time. Nobody can win a race against degeneration.
So
You just have to treat it like fever, treat it with paracetamol.
Thoracolumbar junction, Vishal?
I would just do one level above. It is absolutely not going to change my incidence of proximal junctional kyphosis, whether I stop at L1 or I go high up to D10. The incidence and reoperation rates are going to be the same in a patient where you stop at L1 as a UIV versus a D10 at UIV.
Does everybody agree with this?
No, no. I have a different take on this. I think, Ram, there are two issues. One is the adjacent segment, and second is the segments above your L4.
Yeah.
Your L3 has slipped into a little bit of listhesis, which was not there. Your L2-3 has settled down.
Yes.
So probably an anterior support. See, your L4-5 is the only thing that is holding very stable.
Perfect.
Everything else is seen to buckling. So your posterolateral construct per se is not sound.
Exactly.
So that fusion has never happened. So it is not only the adjacent segment, it is the intra segments also. So you will have to fuse anteriorly at every levels.
And do good lordosis reconstruction. So my take is just do one above, only extension of instrumentation, only one level above. However, when you do one level above, at the same time, try to get as much lordosis as possible at these levels so that your lordosis overall is restored well.
I'm dealing with an 82-year-old man now, and he's now on teriparatide as well.
Yeah. So now the question is, what is his functional expectation? If he's really, really disabled and he's really not able to carry out even his routine activities, we have to offer him a surgical solution, and it is up to him to take it or not. That is besides the point. But if you want to reconstruct this, you have to go higher up. See, the problem is stopping at L2-3 with a degenerative L1-2. Okay, so it's like the thoracic spine is stiff, the lumbar spine is stiff, so you have only an L1-2 mobile. So the decision then was to go up to D11 or not in the first thing. That's a debate right in the beginning when he was 75 years old. So you take him to a stable level. So that was the first thing. And now if you have to do it, you have to do it 11 down to S1 with Ayler screws and a good anterior fusion. But that's an extravagant surgery for an 82-year-old.
So I agree with you. And Mir, I at that time bit the bullet and went to D10. I did not do all that you said, but I tried my level best under the circumstances. And this is about 10 years back or 9 years back. I went above. I went across the area which was unstable, put a domino there and went up to D10. Well, he did well, but only for 6 months this time, despite being on teriparatide, and came back in 6 months with an acute myelopathy, neurology, bladder bowel involved.
At higher level.
He had popped the disc where my screw helped the disc pop out, I think. And this is what he came back with. To cut the long story short, since he had come in 6 months and he needed emergency surgery, we went in, revised him, and this time we learned that if he stopped at D10, we go across the thoracic kyphosis and we went up to D4. This man was grateful because he recovered his neurology. He had some cardiac issue coming in at the same time and started getting investigated for the cardiac issues, was looking at a cardiac procedure sooner or later. But within 6 months of this fourth surgery, he again, having finished teriparatide, came back with yet another osteoporotic fracture and a disc between D3, D4. This caused again a neurology. What do we do now?
Sir, forgive him.
Well, it should have been the other way around. He decided that he needs the cardiac procedure, but before that, he needs us to make him standing. So with all precautions and counseling, by this time he had become a family friend, because if you operate on the same family 4 times, they become part of your family. I went in and did something which I had never done earlier, which is did D1, D2, D3 screws plus sublaminar wires and went up to D1 and said, "Sahab, abhi iske baad mere paas aur kuch nahi hai." Well, he lived well for a year after that and then underwent the cardiac procedure. Unfortunately, did not live longer. I do not know if he would have come back beyond this, what I would have done. But I must share that this was the worst situation of adjacent segment degeneration. after a well done primary surgery, after going over almost 15 to 16 years. We had disc degeneration, instability, stenosis, everything. All the 6 things described happened in this one case. Translation greater than 4 millimeters, angular change more than 10 degrees, severe collapse of the intervertebral space, herniated nucleus pulposus, vertebral compression fracture, pedicle screw loosening and non-union. Everything that you know of ASD happened in this one case. And I think this is what taught me that one, there will be things which may happen usually above and rarely below. If there is a change in the anatomy or geography of presentation, please have a very low threshold for looking for adjacent segment disease. And remember, whatever you may use, soft rods, partially solid, partially soft rods, one-sided rods, I have done all this. Please understand, you may use disc replacements, you may use pedicular-based soft options, interspinous options. Love it or hate it, there is an adjacent segment disease. Prevention and management of this is still a fiction. Thank you all for a very, very patient hearing. I know you may have your answers, I have mine, but the correct answer is somewhere in between, because we have to know that there will always be an adjacent level, adjacent to the adjacent level that we have instrumented. Thank you all for a patient hearing.
Thank you, Dr. Ram sir. May I request Dr. Vinod Agarwal to please start sharing his screen, the last spine case of the day, followed by the foot and ankle and pediatric session and sports medicine. We have a few cases coming up quickly. Dr. Vinod Agarwal, are you around? If Dr. Vinod Agarwal is not there, may I request Dr. Alaric to please come up with his slides, please. Alaric?
Yes, thank you. Thank you so much, guys. And here is my case, which is a fairly simple but common case that I think comes to us as even a general orthopedic surgeon. We're often accused in pediatric orthopedics of bringing across very exotic cases at BOS meetings. So I've taken the precaution to bring something really simple, but at the same time, which is a bit challenging to treat, a case of post-osteomyelitic ankle destruction with a calcaneus deformity. So here is an 8-year-old boy who has progressive calcaneus deformity of the left ankle since 1 year. He has abnormal gait because he walks in a peg-shaped manner with weight bearing only on his heels. The ankle is fixed in about 30 degrees of dorsiflexion. There's no further dorsiflexion nor plantar flexion from that position. There's no subtalar motion either. He has about 2 centimeters shortening of the left leg. Luckily, he has no pain and no distal neurovascular deficit. His X-ray shows that he has a sclerosis of the lower third of the tibia with damage to the anterior half of the distal tibial physis. There's also destruction of the talus and the ankle mortise, as you can see. Give you a bit of a backstory. This child was treated by me, in fact, 4 years ago, when he came with a chronic osteomyelitis of the distal tibia, where there was already destruction of the talus and the ankle joint. I went ahead and did a very aggressive debridement sequestrectomy. As you can see, there was a fairly large sequestrum and a lot of muck inside the tibia. After cleaning that up nicely, we found that we needed to do something more. So we ended up doing filling the defect with antibiotic impregnated hydroxyapatite beads. He grew MMSA, which was amenable to antibiotic therapy. And the infection was controlled well within 2 or 3 months with local measures and systemic antibiotics. So this was his post-op X-ray. As you can see, the defect gradually filling up, the antibiotic beads getting resolved. However, the posterior bone remains sclerotic. The distal tibial physis was damaged, and I kept advising them to come for regular follow-ups. The talus was already showing signs of avian and destruction. At a 2-year follow-up, he was walking well, but I could see that he was landing up with tibial shortening. So I went ahead and did an epiphysiodesis of the distal fibula so as to maintain the difference between the tibia and the fibula. So this is his present picture and the present problem that he's facing now. He has a calcaneus deformity, as I said, of 30 degrees. He has an adherent scar on the lateral aspect of the leg and the ankle from a previous debridement that was done when he was in the acute osteomyelitic stage, done elsewhere. As already enumerated, he has a damaged distal tibial physis, more in the anterior medial part, but there's still some growth happening posteriorly. He has a destroyed talus, and sclerotic bone in the distal tibia. So I open it up for discussion to the panel, the main question being how to correct this deformity. What would be the best approach in view of the adherent scar? Which implants should be used for the deformity correction? How to prevent a recurrence? How to deal with shortening due to loss of the distal tibial physis? And this is not a managed case. I'm really looking for I'm really looking for options to answer many of these questions because it is a bit of a challenge dealing with cases like this. So I'll put up the X-ray and the clinical picture for people to opine.
Do we have Dr. Tushar Agarwal and Atul Bhaskar on? So I would request their comments, please.
So I am here. I was wondering if this child has any residual pain right now.
No, luckily he does not have pain. He's 8 years old now. He's walking around quite well on a peg-shaped sort of gait. That's one thing which he does not have is pain, which is surprising because the amount of destruction that he has in that ankle joint, he's walking quite comfortably. Of course, the gait is quite abnormal.
So, Neil, your comments?
So there seem to be three issues here, and the deformity, probably there is definitely a frontal plane deformity. There is a lot of valgus. There is a sagittal plane deformity in the form of a dorsiflexion, and there is also probably a rotational plane deformity. All of them probably will have to be managed along with a shortening. So this is not quite simple. Probably it's going to require osteotomies, maybe to correct the triplane deformity along with some amount of lengthening and also some amount of bone grafting to see to it that whatever voids are there post osteotomy need to be filled. So not a straightforward case, I would say.
Atul, can you unmute yourself? Atul?
Elizarov with bone transport.
Atul is not there. Rujuta, your comments?
Yes, so if I may just say that, there are multiple problems here and we probably can address in order of priority the one which is the most disabling and which is the calcaneus position. So had we to begun with used a fixator to span across the joint, probably this would have been, it would have fused, it's kind of naturally fused in an unsound position. So what we can do at present is improve that skin and fuse this in a better position, at least to keep it plantigrade. The shortening, derotation, all that can be, I think, achieved much later. Derotation will happen when you try to fuse it in a better position. If the good old Chanley's clamps were around, then that would have perhaps been my choice of getting a sound ankle fusion here, but in a better plantigrade position. However, I believe there are some newer implants now, which probably the foot and ankle surgeons will be ideal to open.
Can you go ahead, Atul?
So this is quite rightly the plan. So it's not just the bone which is the issue, but of course there's soft tissue problems as well. We know that this is a very precarious area of the body for the blood supply. We did angiogram as well and found that the anterior tibial artery was not the predominant supply. It was quite, the flow was quite weak across that. So predominantly blood supplies from the posterior tibial and from the peroneal. So the plan is to involve the plastic surgeons to try and get a better skin cover, because with that adherent scar on the lateral side, I'm scared of putting any implant or doing any osteotomy through this very sort of less vascularized tissue. So we are planning to do an anterolateral thigh flap, which is sort of anastomosed to the peroneal artery, and then do a medial approach to the distal tibia and sort of do a wedge resection of that distal tibia, because that bone is very sclerotic there. I don't think we'll get a good fusion mass, with that kind of a bad bone there. Taking off the remnant of the posterior distal tibial physis and the remnant of the talus, and then doing a tibiocalcaneal arthrodesis as Ruchita suggested, either fix it with an ankle arthrodesis nail, which apparently is available now. I don't know whether the size would fit this child. I found out that the narrowest diameter is 10 millimeters. If not that, then at least maybe a Chanley X-fix. And then to address the shortening as a second stage by lengthening that bone proximity. So that's the plan for this child, and thank you everyone for your comments.
Elizarov?
Yes, certainly. So that's another option as well. I just find it a bit challenging to do, to get all the things corrected at the same time. I thought this was a single one-stage procedure, but that definitely is a viable option as well. So thank you for that.
The next presenter is Ritesh.
Ritesh Nazareth. Please go ahead and share your screen.
So Pradeep is here. We can also take Pradeep's comments on this, where such equinus deformities in kids, adolescents, nailing.
Yeah. So Vishal, Alaric, fantastic case. I think one of the challenge, especially for this case, is to correct the calcaneus deformity. So you will actually have to build up in the front. So in spite if you take the talus off, you will still be ending up with a calcaneus. So you'll have to actually bone graft, take a fibula, bone graft anteriorly, and correct the calcaneus position. I think that is the key thing.
Ritesh, can you share your screen? Ritesh, can you share your screen?
So the key is,
Sangeet, can I suggest?
Ritesh, are you finding it difficult? Then we can go ahead with Kinney's case.
I'm
first.
just.
Abhishek.
Yeah, let Abhishek go ahead with it.
Abhishek?
Yes,
Are you
sir.
around? Yeah, please share your screen.
Yes, sir.
What about doing the tibiocalcaneal fusion trans to the calcaneum, talus, and tibia with a lot of bone grafts?
Yes, sir. We can have the discussion later. We have to finish 4 or 5 more.
Okay, Abhishek, we can see your screen. Please go ahead.
Can you hear me, sir?
Yes.
Okay, thank you. Thank you, BOS. Good meet. So this is a very simple case, very unlike the surgical things that we've seen all day since morning. So this is a painful flat foot in a running athlete, and the purpose to kind of get it through is to understand an adult flat foot and the decision making. So this is a 38-year-old female who's a banker, and as we know in this current lockdown and the corporate culture, they are quite motivated to participate in marathons and prove one up over the others. So she comes to us with like a pain in right ankle, posteromedial hindfoot, since 6 months. So she gives history on proper probing her that her mileage has increased from say like what used to be like a 15-20 kilometers per week to almost 70 kilometers a week in the last 8 to 10 weeks, and that has caused her pain. And as we know, all of these guys can afford and always have a coach and a physio, and has done all the stretching, orthotics, and her pain still persists. So pain is dull, increases on jogging, and because of this pain, her pace has dropped. But she's never heard any snapped or felt any snap in her ankle or back or hindfoot. She doesn't have any systemic illness or any trauma. So on examining, it's very important that you expose right up to the knee from an examiner from the front, from the side, back, standing and seated. There is mild swelling posteromedial to the medial malleoli. There is mild loss of her medial arch. There is tenderness retromalleolar region. There are not too many toes sign. She can perform the single leg heel raise, but she does get pain posteromedial to the posteromedial hindfoot. And silver scales test is positive mildly, like which indicates there is mild gastroc tightness. So these are our X-rays on standing, where you see that there is a drop of talonavicular joint and the hindfoot is slight in valgus. This is our MRI, and it confirms that there is a tibialis posterior tendon split. So with this clinical and imaging diagnosis wise, she has what we call it as an adult acquired flat foot stage 1, where there is tibialis posterior tenosynovitis or a split. It is not stage 2 yet because she can perform single leg heel raise. So it's like a 1, maybe proceeding to 2. So I think with Pradeep here and other eminent faculties, what would be our line of management be for this lady who wants to run and who wants to compete in marathons?
Dr. Antav, and after that, Pradeep.
Yes, sir.
Dr. Antav, are you there?
Does the foot goes in hyperpronation?
Yes, sir. She has hyperpronated foot on rest.
And have you studied her pattern on the of the foot patterns on the machine? How much is the touch, all that?
At this stage, up till here, no, sir. She said that she has got an orthotic done with her physio, who had given us some pictures of that thing, but it was not done by me. It was done before she came to me.
What is the cause of valgus of the hind foot?
I think clinically it is the tibialis posterior, which is slightly being overloaded and heading towards dysfunction.
Abhishek, I would have to disagree with you on this acquired flat foot for the simple reason that the other side, there is also valgus, ankle valgus. And just the tibialis posterior as a single muscle causing this may have been described in literature, but this is probably something which has been there from the beginning. And right now, the tibialis posterior is probably more of an incidental thing than actually causing that flat foot. Because just one muscle causing flat foot with so many joints there is extremely unlikely. I mean, this is my opinion.
Point absolutely correctly taken. So the flat foot etiology is a big combination. So you cannot point it at one point. I agree that maybe it is just the overload that has caused over here. And that is why the whole problem, that is why actually I'm presenting this, that's very important to understand each and every factor which goes in getting us this pathology. Shall I go ahead?
No, wait, Pradeep, comment.
Yeah. So Abhishek, a nice case. So two things are there. One is what Swapnil has correctly pointed out, and we see routinely in our practice. Patients may be flat foot for a very long time, but in this lady, she increased the mileage from say 15 kilometers to 80 kilometers in 8 to 10 weeks. That's completely a no-no for a person who has been training, and especially under whom a coach and a physio is there. Normally, the training should be 10% increase way beyond that number. So that's probably one of the cause where she's flat-footed, no pain to going to a pain. And that's where the tibialis posterior is loaded, and probably she just got an edema or just a partial tear. Second thing is the orthotics. Now we know the fact that especially with these high-end runners or professional runners, they cannot survive with a normal off-the-shelf orthotics. If they are flat-footed, they need customized orthotics. So that's what I would first go and try it with.
I think very correct. I think we'll proceed in view of time. So we discussed the management with her. All the points that I think our eminent faculty just pointed out were discussed. Her demands, which meant that she has been like overloaded way beyond what her body could take, need to offload. We need to review her orthotics and at the same time promote healing, maybe rest and time, maybe orthobiologics, which are in vogue at present. Along with this, it was very important that she focuses correctly on her strength and conditioning to resume her training, like the biokinetic chain, right from the spine, which we've discussed so much up till now, to her foot, like right to her forefoot, I would say, like an MTP joint needs to be discussed. And orthotic review, her original orthotic that she came up was bulky. And as Pradeep pointed out, the apex was at the medial cuneiform, which was slightly distal to which her joint was dropping down, which was modified to offload the talonavicular joint. Physiotherapy to strengthen her foot intrinsics and medial long flexors, her foot core, that's what we call it currently, like all the intrinsic muscles of the foot. We stretched her gastroc, got her onto a specific running rehab with regards to a lower limb biokinetic chain. And she also traveled to Germany and got her PRP done on herself. Like, I'm not a big fan of this, but she did it, which I think has helped her, or maybe or not. And this is where she is. She's running, and she went on to run, I think, the Boston Marathon after all of this, and she's a happy lady today. So I think the lessons learned were that we need to take detailed history in such patients, like increased demand. We need to do a proper and a thorough clinical examination, imaging to kind of find out where we are. Offloading is very important. We need to review our orthotics. Even if they come to us with orthotics, we need to see them, as Dr. Antau sir correctly pointed out, that it needs to be examined by the surgeon or by the physician himself, and also work on the entire biokinetic chain, that's strength and conditioning, right from the spine core to the forefoot. Orthobiologics are kind of questionable. So I would end this with one of our legends, and this is my favorite talk, and sometimes I show it to all of my patients also. So this is our legend from Indian athletics, PT Usha. You can see her foot, like how much is she overpronating, and yet she could get us all the medals. Thank you. So I think it's important that we treat only people who are symptomatic and not all those people who come to us.
Ritesh, you are the next. Abhishek.
So if she continues doing that Abhishek marathon,
Yes, sir.
is she going to get arthritic in that mid-tarsal joint and all, and then she'll be limping. So I think with a flat foot that she has to do something else like swimming.
Not necessary. Not necessary. Kalkani sir.
Bolo?
No, not necessary. I think if they are asymptomatic, as long as they can. So one thing which Abhishek really pointed out, especially people who have flat foot, they really need to be looked at, especially the gastroc muscles, the gastrosoleus complex. And they need to have a proper physiotherapy by a trained foot and ankle therapist who can correct the hindfoot valgus and then do a stretch of the gastrosoleus. Just doing a dorsiflexion in a normal position will not help stretch the gastroc. That is very, very important. And there could be one, and especially with the newer, younger generation, we are finding that these people with a gastroc tightness are causing to a pes planovalgus or AFD or PCFD, what we call it now. So as Abhishek pointed out in one of the lessons learned, that is very important, sir.
So I think it's very important. I would like to extend this corollary. I think hold the flag for foot and ankle surgeons slightly higher and take it way above. So would you stop any genu varus from doing any activities, sir? Never. Then why stop a planovalgoid from being active?
Correct.
So we end the discussion here. We move to the next case. And Dr. Ritesh.
Yeah. So am I audible?
Yes.
Yes.
Yeah.
Go ahead.
So a little different presentation in today's times, a little different from almost all the presentations, I'm sure. Vascular gangrene, but with a twist. A 68-year-old lady who initially stays at Bombay, but she went to stay with her son at Meerut, North India, and only a known hypertensive. In the third week of March, she noticed a small gangrenous patch on the foot. I'm sorry, I don't have those pictures because that is when she was in North India. After consultation with a local doctor and after a few days, she went to a multi-speciality hospital in Delhi. And after meeting a vascular surgeon and doing a CT angio, they found out that there was a popliteal artery thrombus. A thrombectomy was done. Within few days, she was discharged. Everything went well. Happy story. Now the twist started. This is something which she developed in the next 2 weeks gradually. And being my old patients, they were in touch with me. And this was the peak of the COVID season, I guess, in Delhi at that time, because of which travel was not possible. Travel was possible for medical reasons. Everybody was afraid to go out. And over the next 2 weeks, gradually that black patch kept increasing and it reached up to this proportion. Now they were in two minds. They were on phone with their original vascular surgeon in Delhi, who actually told them that everything was right. And he said he needs to review. And they were in two minds whether to come back to Bombay or go back to Delhi. So how do we proceed from this stage?
NGO.
What options do we have? It's a very straightforward case, but it's something different from the rest of the cases. So I felt it to be interesting.
Isn't the NGO the next step to know what is going on?
Whatever is dead has to be amputated.
Right, sir. I mean, by the very look of it, yes, amputation is inevitable. And that is what the patient was told by the primary vascular surgeon, that amputation is inevitable here. Angio was just 2 weeks old.
No, but this happened after that NGO, no? So I think
right, sir. After the revascularization and the popliteal thrombectomy, after that, this happened over the next 2 weeks.
At least get a first arterial Doppler to check what is happening in the lower limb.
Okay. So basically, patient was in a very small village in Meerut, and then they were in two minds whether to come back to Bombay or go back. But what we could see from the past, the history in 2 weeks was that this was an established pattern. The rest of the skin looked good, and perfusion looked good with normal intact skin in the rest of the leg. So that is where this query arised as to, amputation was inevitable. But why did this happen in spite of a good reperfusion procedure? And why suddenly this gangrene? I mean, that lady was absolutely right. She was relaxing in her village. Why did she get this gangrenous patch? And why did suddenly everything start? So I'll just go ahead. Finally, obviously, we planned to do a angio, but because of the high creat, that was not possible. After consultation with the vascular and plastic team, we decided that we will check the perfusion on table itself, including muscle viability. The level was decided. I went ahead and I did an amputation for this patient. The vascularity of the muscle looked good. The tissues looked good. We chose that level and we got a proper amputation. Now our fingers were anyways crossed that we didn't want an issue and a re-amputation at a higher level. Obviously, post-op, after consulting the nephrologist, the creat came down and the angio was done and everything looked good in the angio. So this was done finally. So it's a very straightforward case. Amputation done, everything over. But now comes the twist that the patient kept asking that why this happened, why was the gangrene, why did the gangrene happen, was the initial surgery right? After that, I decided to, just get some more history. That was the peak of the COVID wave in North India. The patient had not taken any vaccine dose. Patient did give a history of loose motions and body ache a week prior to developing the gangrenous patch. And that is where all the bells started ringing.
Black fungus.
I sent a COVID antibody test and it came positive. So obviously, the thrombus or the hypercoagulable state was because of COVID. Some take-home messages from here because, invariably, we will always get these cases sooner or later in the current scenario. We have seen a lot of arterial thrombosis and occlusion occurring in COVID. Generally, the cases are mostly seen by neurosurgeons with brain stroke, presenting with stroke. But yes, when I searched literature, I saw quite a few vascular surgeons and even some orthopedic surgeons getting such cases where COVID has caused occlusion, that also arterial occlusion. And very well, this could have been prevented if it was diagnosed early. If the patient wouldn't have wasted time traveling from her village and going to Delhi, probably the reperfusion would have saved that limb. So if we expect such cases to come in the future, keeping this element of doubt, probably getting a COVID test or probably, keeping a high diagnosis, we can always, intervene and probably save the limb. The another take-home message is that most of the low molecular weights and the newer oral anticoagulants, Eliquis and the other drugs, they are mainly treatments which are advocated only for venous thrombosis. So obviously in this case, we had to consult the vascular surgeon. We had to consult our hematologist. We started on oral warfarin, monitoring the PT-INR. And I guess that has to continue so that we don't want any other untoward incidents in the future. Thanks a lot for a patient hearing and any questions, any debates on this.
Is it reported in literature?
Yes, sir. It is reported. I have checked a few, but
Yes.
it's more or less in literature, probably in publication in the next few months. Maybe we'll see small series coming up. I have seen I've spoken to neurosurgeons who have seen a lot of stroke, but orthopedic surgeons are seeing very less cases. Maybe vascular surgeons are seeing. So probably in vascular journals, we may get publications in the future.
Dr. Nazareth.
Yes, sir.
What was her stage of COVID? Suppose now in the initial stage, the patient is hardly symptomatic and running slight fever and he's in the house quarantine. Now, unless he goes into the second stage where the ACE is attacked by the antibodies, that is cytokine storm and all that, the angiotensin converting enzyme, that is the time when they go into thrombosis. So in this patient's history, if she was in the first stage, she may not. But if she was in the second stage, then of course she would have had to have the long-term anticoagulants.
Sir, as I put it, basically this was an asymptomatic COVID. Obviously, it was not diagnosed, and for that reason, since she was in village, she only presented with body ache and loose motions. Obviously, it was asymptomatic. They did not doubt anything, and every day we are learning something new about COVID. So possibly just with some basic symptoms like loose motions and body ache, also she went into thrombosis.
Ritesh, can you unshare your screen? Dr. Nagaraj?
Yes, sir.
Can you share your screen? And the last comment and opinion of Dr. Agashe. Dr. Agashe, sir, are you there?
Sangeet?
Yeah, Dr. Antha.
My connection was very poor, so I could not see properly.
Okay, Dr. Antha.
Okay.
We have seen this kind of situations in our hospital, right from gangrene like this in COVID stage. And the last that we saw was an ulnar nerve palsy below ulnar nerve artery thrombosis at the wrist, where the patient came with claw hand. So we must be careful about this, about nerve palsies, vascular palsies. Yeah. Okay.
Hazrat, I think what is important to know is that at what if the patient is in the second stage, bodies are attacking the angiotensin converting enzyme in the cell. That is the time when the thrombosis would start. So whereas in the first stage, it is not less, it is less likely.
Dr. Karkhan,
message
two devices open at your end. Close one of them.
Shift our gears now and we move on to medicine and arthroscopy. And we have expert panel Dr. Hetal Chiniwala with us.
Nagraj, can you start?
Yes, I hope everybody can see my screen.
One second, hold on, Nagraj. Swapnil, can you mute everybody because someone has opened two devices and that is why the voice is echoing.
Exactly. Okay, Nagraj, please go ahead, proceed.
So the first case is on basically specialty shoulder surgery, not exactly an arthroscopy, but it is of interest to everybody because it's a fracture dislocation of the shoulder. At the outset, thanks you to the Lilavati Ortho Department and Bombay Orthopedic Society for this opportunity. Now, the case history is that this was a 50-year-old lady who is an avid trekker. She works from home and she presented to a senior orthopedic surgeon with just complaints of mild pain in her left shoulder, which was for about a day. On further history by the orthopedic surgeon, she said that her right shoulder also hurts, which was about 4 days. When he asked her whether she had any history of any injury, she said no. Any trauma, she said no. And she said that this pain started only when she did a stretching maneuver, like when she stretches in the morning. And it was a very relatively mild pain, so to say. On routine X-ray was advised. And on further asking her whether she has any, so first let me show you the X-ray. So the orthopedic surgeon saw this X-ray. He was in disbelief. How can a patient with a bilateral fracture dislocation shoulder have such minimal symptoms? How can she have bilateral problems? And therefore he asked her whether she has any history of seizures. Again asking her any form of jerk, any electrocution, any relevant medical history, and her answer was no for all of them. The only thing she said was she was hypothyroid. So this is the surprising X-ray that was sent to me on a weekend, actually on a Saturday, late evening when we were closing our day. And obviously something had to be done for her. So I called her to my institute. So the plan to all the senior orthopedic surgeons and faculty, what do? Do we do a close reduction on the weekend? Do we prepare for a night of challenge, that is close reduce, and go for an open reduction? Do we go to fight another day by doing a formal open reduction and internal fixation, or any other plan? So let's take a minute and take the opinion.
Nagraj.
Yes, sir.
So I think that this humerus is impaled at the lower end of the glenoid. And this is the fracture dislocation, which normally with the Cocker's maneuver that I might have shown several times, that will fail. So unless you give a different maneuver, that is traction and abduction and anesthesia, this may not reduce.
Okay, sir.
Tell your opinion.
But are we sure that this is a fresh injury, because we are not you are not sure about anything? So in such cases, if it's a chronic one, or maybe it is and if you try to internally reduce without knowing what's the status, you may be jeopardizing the vasculature and maybe the nerves.
Okay, Dr. Hetal is in favor of probably going for a formal open reduction.
Can I say something?
I'm in favor of investigating some more.
I would like to do an MRI for this.
Exactly. I would like to do an MRI first before touching the patient at all.
Okay, Dr. Antav and Dr. Hetal, what are you looking for the MRI?
Dr. Nagraj.
Yes, sir.
Rotator cuff test.
Dr. Antav, please follow the sequence. Dr.
Okay.
Nagraj, for the tuberosity to displace, you require a significant force or the type of a particular injury, which he denies.
Yes.
So on repeated probing, could you elicit something more?
Absolutely. I think Dr. Gawale sir is pointing to something ominous here. I probed her repeatedly. There was no history of seizures. There was nothing in the medical history. And that, I think, in the options, we are very clear that the house is confused as to where we go ahead. But we all agree there is something not right here. Yeah. And therefore, that is what even I felt. And I decided to be well prepared. Dr. Anta sir was pointing out about the relevance of rotator cuff tears. I totally agree. And that can be managed in our open reduction plan. And I was prepared for the same.
Was that some form of abuse?
Sorry, sir. No, there was no form of abuse that I know. Very loving family. The mother was with her all throughout. The husband was with her all throughout. In fact, she's a doctor's daughter. She's not she's a non-medical person, but a doctor's daughter. So very well managed family.
Dr. Anta?
I had a case of abuse like this, fracture dislocation, where patient refused trauma, conversions, anything. And when it was sent, probed very, very, very finely, she agreed. And then I had to, after doing the case, everything, I had to send her to the psychiatrist, the whole couple to counsel and settle the whole family issue.
Point noted, sir. This was not the case here. This is a completely different scenario. So my decision was to not waste that particular night and allow her to be in discomfort. It also gave me a chance to probably see the nature of what I'm dealing with. So I decided to go only for a closed reduction. But I was very careful in my reduction maneuvers to avoid any external rotation, to be extremely forceful, because I was ready to go in for an open reduction in future date. So I did the maneuver where we actually place our foot on the axilla, which gives you a very gentle reduction maneuver and just a gentle traction and counter traction. And I could achieve the reduction on both the sides, on the right and the left side, and it was stable on table. I immobilized her. Now you can imagine she's a bulky lady, and immobilizing her is a big challenge because both the shoulders are involved. And this was the post-op X-ray. When I went for the round the next day, I was suspicious on the left side with respect to her deltoid appearance, and I suspected that she might have redislocated on the left side. So we got a CT scan done of both the shoulders. And that is why my fear, she had redislocated on the left side, telling me that there is something more ominous, especially on the left side. So this is what we had on the immediate post-op. Now my mind was more focused on what could be the reason, as Dr. Gawale sir was pointing out, why is she having such subtle history, but such major orthopedic findings? So any clue, or shall I go ahead with what I did?
Please go ahead.
So this was what I saw.
Nagaraj, let us have our panelists here. Hetal, what raises your suspicion here now? It was reduced, it has redislocated. Is there any shallowing of the glenoid? Is there a muscle tear, or is there something that you suspect more?
So there is a soft tissue impelling inside. Maybe there is a capsule. Maybe there is a rotator cuff which has invaginated into the joint and redislocated. So that is why the first thing was that probably doing a close reduction at this stage was not right before investigating, because but any which ways it achieved on the other side. So it's fine, no harm done. But I'm sure there is some soft tissue impelling inside which has caused redislocation.
Absolutely. So my job was to initially just make sure that a discomfort goes less, see the nature of the fracture, start the process, and therefore I had a high index of suspicion of something neurological happening. I knew that there is something fishy going on here. So I convinced the patient for an MRI brain and a screening of a whole spine, which she was very adamant. And being from the doctor's family, they were like, why do you want to check my brain? I've got nothing wrong neurologically. I needed a lot of convincing. And this is what the MRI brain showed. So these are target lesions. These are seen in the frontal lobe and in her occipital lobe. There are multiple such lesions. And for those of us who are not aware what this is neurocysticercosis. And this was a shocker for the family and for me and for the concerned physician. And when we asked her history, whether she's a non-vegetarian, the answer was no, she's a vegetarian. She's an absolute vegetarian. And when asking her, how could this be possible? Even she read it and she said, how could this be possible? And she says she goes on a regular treks, and there they eat a lot of these, in the mountains, they eat a lot of these foods which are not so well cooked. salads, etc. And that could be one of the sources where she got this tinea in her body. Now going ahead, now coming to the orthopedic problem, I know what is going on. So the approach that I had was to involve a neurologist, was to involve a physician and infectious disease specialist. Both of them said that please give us a few days to stabilize her. We'll start her on some steroids, anti-seizure medicines. Now, an important point here from the physician was I will not give her antihelminthics right away. Because if I do that, these schizons will burst and that will clearly give her seizures, which she as of now doesn't have any account of. So we took about 3 to 4 days to stabilize her. The physician was of the opinion, you go ahead with your surgical planning, and once she stabilized, I'll give her the anti-helminthic treatment. So I would go ahead with my presentation that I decided to do a single stage open reduction in terms of fixation, taking care of all the factors that Dr. Chiniwala mentioned, that if there is something impaling the reduction, I'm going to reduce it. I'm going to be ready for all fixation modalities. I'm going to be ready to treat the rotator cuff pathology. All of this is in my anticipation. So this is the classic technique we rely on, is the double row technique. So in addition to traditional fixation techniques, whether it's screw, plate, depending on the size of the fragment, we make sure that we have sutures passing through the bone tendon junction. Multiple such sutures are then parachuted or in a double row pattern coming all over the fragment, and distal to the fragment, you fix it with either screws or with knotless anchors. So this is the important take-home message. Whatever fixation modality you do, make sure you have this additional fixation from the bone tendon junction to distal to the fragment. With this in mind, I decided to go for an anterolateral or a deltoid split approach on the right side, because that was the side the close reduction told me is something I can manage. It was a large fragment, so I decided to keep many screws open, and in addition to that, I had done the hybrid fixation. So I opened the right shoulder in a transdeltoid approach. I went with suture anchors on the fracture crater, but there was no hold whatsoever. So I took inverted mattress traction sutures, which I used to get the reduction also, which I intended to put on a knotless anchor later on. So that was my hybrid fixation. I placed screws to fix the fracture back and the knotless fixation to give a hybrid modality on the right-hand side. On the left-hand side, I was worried because she had dislocated again, whether I need to do some additional procedures. So I went for a deltopectoral because that would give me more options anteriorly. On the deltopectoral approach, I again took traction sutures. I tried to place an anchor here. Again, I didn't get hold, but I got one triple loaded anchor inside into the fracture crater right at the subchondral bone where you get excellent hold. And from there, I created a knotless construct only. Now on the left side, I will show you the images, she's got a significantly comminuted greater tuberosity fracture. So any of your traditional screw techniques are not going to work here. The suture anchor technique was a blessing, and I'll show you why in her follow-up also. So this is our immediate post-op. On the right-hand side, there is a hybrid fixation. So there are about 3 or 4 screws which are compressing the fracture. Additionally, there are these biocomposite knotless anchors, one on the fracture crater at the subchondral bone and one distal to the fracture in a knotless fashion. On the left-hand side, the only screw that could get hold is a titanium screw. You can also use 6.5 titanium screws for such soft bones. And then there is a knotless biocomposite anchor in a double row fashion. So this is her follow-up on 2 weeks. She developed some heterotropic ossification on the left shoulder. I was worried on seeing the right shoulder X-ray that this fracture why is it compressed and collapsed? I did get a CT scan, but to my happiness, the fracture had well reduced. As you saw the preoperative CT scans, these fractures can have a significant pull of the rotator cuff, pulling it posteriorly, and therefore it has to be reduced in a very rigid fashion, otherwise it will come off. This is the actual images which shows that the greater tuberosity has come all the way. It is not to my satisfaction, it has got compressed, but I decided to go ahead with the conservative management. On the left-hand side, you can see the amount of comminution that is there on the greater tuberosity. So it is my traction sutures and my anchor sutures which are incorporating the posterior cuff, that is the infraspinatus teres minor, the infraspinatus proper, the supraspinatus, and all of them being loaded onto a knotless anchor, which is making sure this entire comminuted construct is maintained. So that's our actual image. So you can see this, the amount of comminution, the sagittal split that is there, but it's all been held together as of now. This is a 2-month follow-up. Everything is going well. This is she at 2 months. Now, I'm worried on the right side, but she's slowly improving. She then gives me a call that she's had a first known formal seizure episode 3.5 months post-surgery. She actually fell from the bed because of non-compliance of anti-seizure medicines, which I had and the neurologist had insisted, please do not ever discontinue this. And she was like, "Doctor, I have never had a seizure. Why are you telling me to take all these meds?" And she discontinued them and had her first formal seizure. And my heart was in my mouth to see what's a post-op X-ray. But fortunately, everything was holding well. And I think this is because of the hybrid fixation and the concept of making sure that your cuff bone junction is well stabilized in a double row manner. And this is she at a final follow-up, which is recent. And she's finally compliant now with her medicines.
Perfect. Get it inside, get it down, outside.
This is a full range of motion. My take-home message is think out of the box for these rare presentations. The first thing that struck me was there was a disproportion between her symptoms and her X-ray and CT scan findings. Involve a team of people. Do not go alone on a day when you are not well prepared to do this. Use CT scan judiciously to understand the fracture pattern in both the axial plane and in the anteroposterior plane. And use the double row concept in addition to traditional fracture fixation, what we call as hybrid fixation techniques, to make sure that these are stable fixations so that they don't fracture themselves, because there is a risk of having the seizures again. So you need to have a very strong, robust fixation. And that's my take-home message. Thank you.
Nagaraj, you will have plenty of questions. So first start with Heathal.
Yes, sir. Sure.
Yeah, no. So right now the mystery remains as to what was the cause of her first fracture dislocation, because we found cysticercosis, but she didn't complain of any injury or any convulsions. So whether it happened in sleep, which she didn't recognize, the convulsions happened in sleep, which she didn't recognize, and it happened. And did you ever try to do EMG nerve conduction studies or anything? Because if the dislocation is chronic, maybe there is an axillary involvement, which may, kind of delay the functional recovery.
Great. So a couple of points Dr. Hetal has brought up. Yes, the neurologist also and the family also were convinced that probably she's getting these myoclonic severe jerks in sleep, and that nobody's noticing it because it's happening in sleep. And that is clearly the reason she had this, because her EEG, her electrical activity, clearly showed that she has seizure activity, after which actually the family got convinced.
But so Nagaraj, that will give rise to a posterior dislocation.
Exactly, yeah.
Why anterior?
Not necessarily, sir. Not necessarily. Posterior dislocation is basically the direction in which the jerks will happen. So, for example, posterior dislocation is basically suggested that there is a violent jerk. Doesn't necessarily mean that every jerk is violent enough to cause a posterior dislocation.
Swapnil, your question.
Yeah, so Dr. Nagaraj, there is an entity described as congenital insensitivity to pain, and sometimes it is focal. Something of that sort will also have to be kept in mind, because its picture doesn't really fit in, UMN kind of a thing, causing fracture dislocations and secondary just to this myoclonic jerks looks unlikely.
Swapnil, point noted, but she's a 50-year-old lady from a medical family. If anything like that is there, I'm sure it would have come up in her growing years. She's an absolutely normal lady who had this issue. So if there was any congenital pain issue, it would have come up, is what I feel. The EEG activity actually pinned the diagnosis to those lesions, and those lesions were active. They were active lesions, and she was having myoclonic jerks, etc., in sleep, which led to this. I had evaluated her clinically for her axillary nerve, because yes, that was important. So as we know, we can evaluate it clinically for both the anterior, middle, and the posterior deltoid. So her axillary nerve was fine. I didn't do a separate EMG NCV for that, because I was sure the axillary nerve is working well.
Dr. Agashe?
Yeah, phenomenal idea of doing an MRI. Why did you think of doing an MRI brain?
I think God was with me, sir. I have never seen this, obviously. I have never seen this, obviously, and most of us wouldn't have seen neurocysticercosis in our practices. But I knew that there is something neurological. And like Swapnil just pointed out, I was thinking, let me involve the central nervous system, the peripheral nervous system, whatever I know. So MRI brain and the entire spine, just to make sure the entire neurology is covered.
Harshad's question.
Yeah, so people having convulsions have a post-ictal state where they forget about the convulsions. The only evidence of convulsions is any injury which is left behind. Now, she may have had a convulsion at the night time where she not realized it, or she's forgotten in the morning, and she's never had any direct resident or residual obvious injury like a CLW, or sometimes they get obvious bruisings. This patient may not have had that. So it is related to a convulsion probably occurring in the night time where she doesn't remember. She may have fallen on the bed, gotten up, and they have a post-ictal stage where they are a little confused and they don't remember it.
It is so wonderful to see orthopedicians going behind the exact cause of a fracture. Cause of a fracture ke piche, you know, the orthopedicians snarking around their brains into it. It is amazing. I'm feeling so proud of being an orthopod now.
Mystery always stimulates us. There's a mystery.
Yes. On behalf of all the trauma surgeons, I have two questions.
Yes, she is painless.
No. One is, considering the tuberosity were such a large fragments, why did you not, the dictum is larger the fragment you put a plate, and you did a double row footprint suturing. Okay, that is one. And second is, being an orthoscopist, what did you do to the anterior capsule, or if there was a Bankart lesion or something? You didn't address the anterior laxity.
Yes, so two questions, wonderful questions, sir. So first thing is about the plate fixation. I was prepared for it. It was on my table. I had taken the anterolateral approach because as you saw on the right shoulder, there was a significant displacement of the fragment posteriorly on the right side. So my concern on the right side was the displacement, on the left side was the comminution. So on the right side, I wanted the anterolateral approach so that I can approach it end on, do the releases, subdeltoid adhesion releases, get the traction stitches, get the reduction. Now the fragment did appear to be very large, but it did not appear to me that I should dissect the nerve, I should slide the plate down, take the effort to do the plate fixation, but point noted, that should be one of the options you have a rigid fixation. So therefore I used about 4 screws to compensate for the strength of a plate. In addition to that, I used the traction sutures, and on table I checked for the rotations under CM, and I was very confident that this is going to be stable. As for the anterior capsule on the left hand side, yes, that was my concern. Are we dealing with a patient whom I have missed any sort of a anterior glenoid injury? So if there is a locked fracture dislocation, in addition to that, if there is a bony Bankart or a glenoid fracture, that has to be addressed, because otherwise this patient is going to redislocate. So I was prepared on the left-hand side for this case scenario, and therefore I went for a deltopectoral approach. If I felt so, I would have taken a upper L-shaped tenotomy of the subscapularis. I would have addressed the glenoid pathology. I would have done the Bankart repair or the bony Bankart repair, done the repair of the subscapularis. And most importantly, on the left side, I did was the rotator interval tightening. So you need to take stitches about 2 or 3 between the anterior supraspinatus and the superior aspect of the subscapularis. You need to do a biceps tenotomy to make sure that you don't create any biceps related pain, which was done on both the sides actually. And good you pointed this out, sir. On the right hand side, her biceps are actually subluxed. So I had to do a tenotomy on the right hand side to get the proper fragment reduction.
2 last question, don't repeat. Dr. Mukhi first and Dr. Karkhanis.
On a lighter note, Sangeet, if an arthroscopic surgeon does a plating, then it's not sexy to present in arthroscopy meetings. These are looked upon as a lesser evil.
No. The amount of displacement, on the right side is not acceptable to the orthopedic surgeons.
Yeah, sensibly it's a plating. But on a lighter note, it's not sexy for an arthroscopic surgeon to use plates. So.
Dr. Mukhi first, Dr. Karkhanis last.
One is that there is no pain. And second thing is that when they fracture, they do not have labral tears. What's your take on that?
You're absolutely right, sir. The force is in a different direction. The mechanism is totally different. The brunt is borne by the bone and not by the soft tissues. But we need to remember she's in a category of 50 years. So her rotator cuff is the additional component in the soft tissue that's going to get damaged. So fracture dislocation can involve rotator cuff damages rather than glenoid components. But we need to be careful of evaluating the whole circle, the anterior structures, the posterior structures, and repair each one of them in the treatment.
Dr. Khan.
Dr. Nagaraj.
Yes, sir.
You said that you have put those 4 screws and there is no plate. So the 4 screws probably have gone too much, and that you have over-compressed that fracture. Suppose you had put a plate for the large fragment, as Sangeet had said, then that over-compression may have been avoided. So the take-home message is, even suppose we put a screw in the, say interlocking nailing, when you put that derotation screw, if you don't stop it, the screw might go right to the lateral cortex into the medial cortex, because there is no plate, there is just a nail. So I think that is the cause that it has got over-reduced and over-compressed, because you put 4 screws there.
Absolutely. And when the patient is, even though you're not mobilizing the patient with the basic movements also, there is a contraction of your rotator cuff. So you're absolutely right. There was a compression effect. Plate would have been a good option. It was available on my table. But conceptually, I was ready to give her a robust fixation. And this was an effort to give her that.
So we conclude this by concluding a message from trauma surgeon to the scopist. Believe in plates also.
Yes, sir. Sure.
Dr. Sangeet, can I ask a question?
No, sir. Sorry, sir.
Sangeet.
Okay. Hold on. Meanwhile, Dr. Vinod shares his screen. Dr. Antav can ask.
See, in our veterans forum 2 years back, I had presented about fracture dislocations of the shoulder, and we had shown when there's a big piece, you have to put a plate and for fixation. And also when there is fracture dislocation, there's fair amount of capsular laxity or leveler tears which have to be fixed up to prevent the subluxation that occurs post-op.
Rajesh, you were saying something?
No. I think Vinod doesn't appear to be
in a mood
responding. So I think Vishal can present his second case or it is 120. I don't know. What is your take? All of us have presented one cases. There are few who were to present second case, and Vishal was the one of them.
So, probably is he going to adjust? I mean, Vishal.
Yes, sir.
Is it a different case from what has been presented earlier?
Yes.
Yeah,
I think it's I'll just quickly summarize about the case scenario. It's just an interesting case on C2 tumor. Just to complete the picture, we have seen cervical spine today. We have seen lumbar spine today. We have seen thoracolumbar spine.
We've seen a brain tumor also.
And we saw some brain work also among orthopods. I'm just taking a little lower than. So I'm taking it to non-brainy level of craniovertebral junction, whereas C2 tumor in a 56 female presenting with early myelo, just getting off the feet, only some neck pain, recent onset. And then that's the kind of x-rays and MRIs by the time patient presented to us first time. Patient is a walker, but just getting off the feet, having some spasticity early in the lower limbs, nothing in the upper limbs there. And JOA 17/18. And this is the kind of picture there. Like for any other suspicious bone lesion, we went in to do a biopsy and also a CT angiography to see what is the status of vertebral arteries. It turned out to be a cordoma, which has not only involved the interior full body of C2, but also is involving one side of the C2 pedicle as well. And now the question is, what next? How do we proceed with this? How do we excise this tumor? And if we have excised the whole C2 along with C1, how do we reconstruct it? Dr. Ramchada, very quick comment on that, and then I'll just conclude on what I did. It's an innovative way of how we reconstructed to this.
Vishal, I have just an experience of one such case in my lifetime, and I can share it with you. I presented it in the past. I did a posterior occipitocervical stabilization, and then I went from the front and put in a large expandable cage, which took right from C3 to the clivus. And that's the way I had done that. And it is very important to remove a chordoma. Chordomas tend to live very well. Chordomas, if surgically removed, that's the only modality of treatment. Nothing else works. So you should do a complete excision of the tumor as far as possible. So stage 1, posterior occipitocervical stabilization. Stage 2, we did transoral. You may do it high cervical, and went and put in an expandable cage from clivus to C3. Thank you.
Right. Priyank, anything different than what Dr. Ram mentioned?
Exactly what Ram sir said. Like as far as the surgical plan is done, and you'll require a lot of expertise like an oncal surgeon or an access surgeon, because reaching C2 is the most difficult part anteriorly. So if you're able to go there, then half your job is done. So that's where I'm waiting to hear what you have done for this.
Oh yes. So I think the challenges are very clearly mentioned by Dr. Ram.
Also, if just 1 second, it's just come in now. But in general, for everybody's benefit, if suppose this case comes to someone who's not able to do surgery and get the chordoma out, the other alternative treatment is proton beam treatment, which also has a equally effective result in controlling the chordoma. But it's really very expensive, and in India right now, it's only there in Apollo Chennai.
Yes.
So,
good.
Yeah.
Priyank, you brought this point. And high proton beam therapy is recommended only in a stable spine where there are no pathological fractures imminent there. So unfortunately, this patient already has a pathological fracture of C2 chordoma. We all know chordomas are locally aggressive, benign, malignant lesions, which also have a tendency to spread if not taken care well. Unfortunately, they are so slow growing that by the time patient presents to you, they have already spread extraosseous, and the chances of you doing an en bloc resection with clear margin is already lost. So we have missed the bus by the time patient comes to you. The chances of wide excision is gone. So whatever we do is going to be a piecemeal. So knowing that this patient is going to have a piecemeal excision, knowing that this patient is going to have a recurrence, the C3 to clivus reconstruction, though has worked well earlier also, but it is also recommended to reconstruct it as locally as possible, knowing that reconstructions at a later date will require clivus to be engaged in. And what we did was, in stage 1, we went in through the submandibular approach, which is again a very, very difficult approach. Like we just discussed, these are some papers in there which I mentioned about this clivus to C3 reconstruction. However, in our case, what we did was embolized in morning, took the patient in afternoon, did a submandibular approach, which is a terrible quadrante where there is just behind the digastric triangle, there is a facial artery, lingual veil, hypoglossal nerve, submandibular duct, and any of these can just make the patient into disastrous situation. What we did was the excision of complete C2, preserved the C1 lateral masses, took the C1 arch anteriorly from the tip of odontoid, everything was excised, and we reconstructed from C3 to C1 lateral mass using a fibular graft and dental plates there. And that's the kind of picture post-operatively we got. And this is like the final CT scan at 2-year follow-up without anything. So these are 2 cases that I have done so far using dental plates from the C3 to C1 lateral masses using allografts there, and then supplementing it posteriorly with OC fusion at a later date. And this was recently published also. And these are the 2 cases. Of course, high dose proton radiation therapy is something that is important, but so far 2.5 years post-op, both our patients are doing really wonderful. Wonderful fusion noted from O to C junction here, and a nice fusion that has happened between the C1 lateral mass to C3 vertebral body as well. So this is an innovative way where we have not gone to the clivus, hoping that reconstruction recurrence doesn't happen. But if recurrence happens, we'll again go and debride, excise, piecemeal, and then maybe we'll have to jump the guns to the clivus there, which we have saved it here. I would just sum it up here.
So we come to the end of this clinical meeting. We had excellent number of cases. Probably the last clinical meeting at Lilavati was, I think, 4 or 5 years back. Am I right? It was a half meeting.
I don't think we've had any at Lilavati.
Okay. So considering it was a first meeting, we are all very happy with the number of cases, the variety of cases, and we had so lovely discussion. So
I really thank you, Sangeet and others, for giving us this opportunity. And I think all of us together really were very keen, because these clinical meetings of BOS are favorite of all of us right from the residency days. And I think it was a great honor to have it, and hope that we continue to do it in future. Tremendous discussions, and thank you very much for everyone to be so patient.
Yeah, and each of your faculty, each of your presenter has done a hard work for making that presentation, finishing in time. So we all thank all the presenters, and also Sun Pharma, who were the sponsor for this event, who were behind us for sponsoring it. Swapnil, any comments before we conclude?
I think we would like to thank the dynamic Vishal Kundani for putting in a lot of effort.
Absolutely. It is Vishal all the way.
Yeah. So an applause to him before we end this meeting.
Thank you, sir.
So we can stop recording, and then
just before we go ahead, I would like to take this opportunity not only to thank the Lilavati Hospital faculty and the BOS for considering us for conducting this meeting, but also the expert panel without whom this meeting, the discussion, the intellect that involved the academics to a level where it is today wouldn't have been possible.